Is it also on YouTube or FB or something? Hello.
Hello, Dr. Venkatgiri sir. Good
Hello,
evening.
sir.
Good evening.
Hello, sir. Good evening, sir. How are you?
Good evening, Pankaj ji.
कैसे हो, sir?
Hello.
Good evening, Manisha Katikar madam.
Hello.
Good evening, Shilpa madam. Good evening, Venkatgiri sir.
Good
Welcome to
evening.
Maharashtra.
Good evening. Good evening. Thank you.
Hello, Manisha madam. How are you?
Pankaj sir, good evening. Fine. I'm fine, sir.
Sir,
good.
can you please?
Are you starting on time या कैसे?
In that PDF, the link is there. So that registration will come on email. No, you can join. You can join, sir. Dr. Venkatgiri sir has joined.
Can I check my slides whether it is correct?
Yes.
It's slide share.
Varsha madam, can you help Dr. Venkatgiri to share the slides?
Yes, ma'am. Sir, please click share button.
Meenakshi. Good afternoon, Meenakshi ji.
Dr. Avinash also has joined. Avinash sir has joined.
Welcome, Dr. Avinash sir. Welcome, Dr. Avinash sir.
Muted,
Dr.
sir.
Yogi.
Avinash sir, you mute आहात तुम्ही.
Varsha madam, can you allow the participants to unmute themselves?
Sorry, ma'am.
Welcome, sir. Nice to see you.
Good evening, everybody.
Good evening, sir.
Avinash sir, you always look so fresh.
Thank you.
कुठल्याही वेळेला you are always with your background and all, you are always ready. ISA logo and on the Jubilee
Yes.
logo also is always there on your shirt. Nice to see you.
Thank you, ma'am.
And Bhatt sir is there joining from Australia.
Wow.
Hi, everybody. Thank you for allowing me to join.
Sir,
What's the time there, sir? Is it midnight?
It's almost 11:30 now.
Wow.
Everyone goes off to sleep at 9:30 over here. Good. Good to see you all. I'm feeling really happy about that.
Good evening, Preeti madam.
you are mute, Dr. Preeti.
I am absolutely muted by our dignitaries from different parts of our countries. Welcome to our national dignitaries as well as state dignitaries. I see Dr. Venkatgiri sir, I see Dr. Meenakshi Sundaram sir. Warm welcome. Dr. Gupta sir, I've been listening into you.
Hello.
Katikar madam, always there. Dr. Avinash Bhosle sir.
Hello.
Welcome
Thank
to
you.
one and all.
Hello, Yogen sir.
Hello, nice to see you all.
Great, sir. Great.
always
Great. After a
pleasure.
long time.
Yes.
Dr. Meenakshi Sundaram name is coming as Dr. Venkat Giri again. Why is that so? Double Venkat Giri. You have a duplicate, sir.
Dave may have shared the link.
I think sir is traveling.
Yes, sir.
He was not able to join, so he joined through my link, Meenakshi Sundaram. He was not able to join.
Okay. Yogen sir, you're in.
Sir, please unmute yourself.
I have unmuted, yes. Yes, I am traveling currently. I am in Australia. It's almost 11 o'clock over here, past 11.
Oh.
And things are quite dark by 6 o'clock. And everyone around sleeps by 7:38 and 9 p.m. max to max. The life is different over here slightly.
Oh, okay. Because I remember Shilpa madam telling me you are probably going to Australia.
Yeah, I am at Australia.
Returning back when, sir?
April 1st or 2nd week. Let's see.
Oh, so March end you're not there.
No, March end I'm not here.
Okay, so Dr. Venkat Giri will have it.
But that meet which Dr. Venkat Giri has given the topic to two of us, I'm sure I'll try and justify that.
Okay, great.
Right. Dr. Shilpa, is it time to go in now?
Yes, sir, we can start.
Yeah, it's 5 o'clock now. I think we can start off now.
Yes.
We already have about 30 members. Yes. Shall we start?
Yes, sir.
Good evening, all members. Unfortunately, I'm not around in India, but I'm traveling. But it is really good to see all of you again today. And nice to hear big names in our meeting. Dr. Meenakshi Sundaram, my friend Dr. Venkat Giri and Pankaj Gupta ji are also there in the meet. And so many of our new members are going to speak or compare the meet today. And Dr. Twisha also, I'm welcoming her also to this meet. It's good to have a slightly different kind of meet where diet and exercise. I'm lucky to have lost about 9 kg in last 1 month. So I really feel the importance of that thing now. All the time I used to be running around in Mumbai, but now I'm feeling that it is a good part of the series that is kept by Dr. Shilpa. I am really happy for that. I welcome all of you. Please go ahead, enjoy the feast of the meat. Thank you. Thanks a lot.
Today we begin the meet by remembering our late Dr. Lalit Mahedrita sir. Sir was chief editor of IJA. He got Can we have 1 minute silence in remembrance of our beloved Dr. Lalit Mahedrita sir? Can we begin the meet, dignitaries? Allow me to start the meet. Today we have with us a very eminent personality, a person so humble, so knowledgeable, and so cooperative. Of course, all our other leaders are also equally cooperative and encouraging. I welcome our National President, Dr. Venkat Giri sir. Sir, it's a great pleasure to have you at ISA Borivali. We all welcome you. Dr. Venkatgiri sir is MD, MBA, FICA, PD, DMLE, PGD, HHM. Current designation as Senior Medical Consultant in Anesthesia. He is affiliated to General Hospital Kasaragod in Kerala Health Services. At present, Sir is our President ISA National. Sir was past Secretary and GC member of ISA National. Sir was past President and Secretary of ISA Kerala, past President and Secretary of ISA Kasaragod, Professional Wellbeing Committee member of WFSA from 2016 till today. Till next year, he is a past Joint Secretary and Vice President of IMA Kerala. Sir is past President and Secretary of IMA Kasaragod. Attended more than 250 state, zonal, national, and international conferences of ISA and other associations. He gave talks and chaired sessions in many conferences. We welcome you, sir. Thank you for your humble presence. Would you like to say a few words, sir?
President Dr. Yogen Bhatt, Secretary Dr. Shilpa, ISA Maharashtra President Dr. Manisha, Secretary Avinash, my good friend Meenakshi, Pankaj, and other friends and dignitaries and faculties. I'm happy to attend this ISA Borivali, this special meeting. It is not only scientific, our topic. The other topics like exercise and other things, which I was always telling in every meeting that we should have some topics other than anesthesia in every CME, like work-life balance or how to save, how to invest and all these things. It's a good that you also have this topic like this, and members will be enriched because there are, you can read in books the subject and all, but not any books are giving about these things like lifestyle or work-life balance, how to cope up with others and all that. We always need that, and we have a good this thing. I wish all the best and hope more and more people will join and take benefit of CMEs like this. Thank you.
Hello. Hello. Yeah, now I welcome our MSc ISA office bearers. Varsha madam, can I have the next slide, please? First, I welcome our president, Dr. Manisha Katekar madam. What to say about madam? Madam is the most dynamic and versatile leader with a vision and insight. She will inspire every anesthesiologist and bring best in her. It's not only the academics, but the extracurricular activities, the cultural activities, the art, hobbies, everything. She will make each member realize their potential and she will help them to come forward. She will listen to each member and help them. To tell her any academic problem, non-academic problem, madam will definitely help you out. Her journey in MSc ISA has been 14 years long. As a GC member, as a MISA News editor, as an honorary secretary, as a vice president, and now president. She has not only made MSc ISA academically sound, we have a lot of regular meets which are very interactive, very interesting. She has introduced the concept that polls should be taught to each and every member of ISA as well as each and every citizen. She has not only helped in cultural activities in developing the hobbies, but she has also helped to understand the concept of fit anesthesiologist. Because of her, today I'm inspired to include all other topics along with the academic topics. And hence, she has committed herself to upliftment of MISA. Madam, we welcome you. We give a warm welcome from ISA Borivali. Namaste.
Namaste.
Would you like to say a few words, madam?
Yeah, definitely. And thank you, Shilpa madam, for such a nice introduction. I'm really humbled and I think I'm really honored. And मराठीत म्हणतात ना हरभऱ्याच्या झाडावर चढवणे. Somewhat that kind of feeling I have got today. Respected Dr. Venkat Giri sir, it is a pleasure to welcome you again in Maharashtra. We keep on seeing you on virtual platforms, and I think the time has come to meet physically. Maybe in Aurangabad, ISS sponsored CME, we will be meeting physically. Sir, I've seen you working as the Secretary of National ISA, and you worked so hard for National ISA. In fact, you inspired me when that time I was also Secretary of Maharashtra State Chapter ISA. And your working pattern, your style of working, you inspiring the ISA members, working for the society, you really encouraged that time. And I must say that your working pattern as secretary really inspired me, influenced me to work as secretary of Maharashtra State Chapter ISA. So whatever Shilpa madam has said up till now, the credit I think must go to National President Dr. Venkat Giri sir, because when he was secretary of a big ISA, I was the secretary of Maharashtra State Chapter ISA, and he definitely used to meet us frequently, used to guide us frequently as a secretary, and he always encouraged. Sir, you have blessed Maharashtra always. As a president of National ISA, I request you to bless the Maharashtra State Chapter ISA. Sir, welcome to Maharashtra. I also welcome our other faculty, Dr. Meenakshi Sundaram sir. He is very dear to Maharashtra, ISA, and a very good friend of Maharashtrians. So, sir, welcome again on the platform of Maharashtra State Chapter ISA. Welcome Pankaj Gupta sir, who is our own member, very enthusiastic and dynamic, and private practitioner, private practice coordinator for the National ISA, always working hard and a good friend of mine. Welcome Pankaj Gupta sir.
Thank you, ma'am.
And respected Dr. Yogen Bhatt sir. It is seniors like you who make us continue to work. We are so young to you, sir. But at 11:30 in the night, right from the Australia, you are there live on the live on the social media, on the Zoom platform, and your enthusiasm is always encouraging not only Borivali ISA member, you are a respected member of Maharashtra State Chapter ISA. Sir, I must say that you are a lucky president also. In spite of you not being there in the Borivali ISA, the platform of ISA Borivali is continuously moving. And I must say, you have got a very lucky team. The young, dynamic, energetic, with a capacity to work like anything. She has the capacity to work for ISA with the earnest zeal. Dr. Shilpa Tivaskar. So enthusiastically, she is working for Borivali ISA. And Shilpa, I must say that I'm really amazed by your talent. I send you a message at any time of the day and you are there always with a reply. And when people like you are there as secretary in our tenure, I must say that the whole team Maharashtra State Chapter ISA is blessed to have enthusiastic people like you around who also inspire and encourage us to work more and more. Whatever we tell you to do, everything is available within 12 to 16 hours, and that is the way why the Maharashtra ISA is at the moment growing. Shilpa is also accompanied by Dr. Neelam Nalke madam, the scientific chairman of our the third biennial CME, which will be hosted in November in Borivali. She will not leave me unless I satisfy all her queries regarding the scientific program. And I must congratulate Yogen Bhatt sir to have an excellent member like Preeti there in your team as a treasurer for the conference. She is multifaceted, multi-talented friend of mine. I have seen her working as a good anesthesiologist, an excellent poet, a versatile artist, and a very good and caring mother, and of course a good wife. Preeti, thanks for being there for Maharashtra State Chapter ISA. Dr. Avdut Kulkarni sir, Dr. Ganesh Tendulkar sir, your enthusiasm to work for Family Benevolent Fund is always seen, and we will always do good for Family Benevolent Fund. Dr. Rajesh Rao, sir, it was very nice to listen to you in the Pimpri Chinchwad meeting, and we'll definitely keep your topic on the platform of Maharashtra State Chapter. Thank you, Shilpa Madam, for inviting me here on this prestigious dais of ISA Borivali again. I'm waiting forward for our first governing council meeting in Borivali in the month of maybe when sir comes back, you can decide with it. Thank you. Thank you all.
Thank you so much, madam, for your kind words. We are really blessed to have all these leaders during our tenure. And now I welcome our most dynamic honorary secretary of MSc ISA, Dr. Avinash Bhosle, sir. Dr. Avinash Bhosle, sir, is again in this MSc ISA since last 14 years. Sir has been the secretary of Satara. Sir has been very helpful in for making us very focused on each activity. Like even if you can tell him any problem, sir will say first consider your aim. What is your focus? Focus on that and forget everything. You just give your 100%, your hard work, and you will be successful. Sir, it is your kind words and encouragement. And you are digitally so active. Everything is ready so fast. I forgot to mention this year MSc ISA, because of your and madam's leadership and because of the entire executive team of MSc ISA, we passed the awards, about more than 75 awards for MSc ISA. Welcome, sir.
Thank you, Shilpa.
Yes, sir.
Thank you. Good evening, everyone. Respected President ISA National, Dr. Venkat Giri, sir, Dr. Meenakshi Sundaram, sir, Dr. Pankaj Gupta, all the office bearers of Maharashtra State Chapter ISA and ISA Borivali, all faculties, delegate, and my friend. I warmly welcome you all. First, we should really appreciate the energy and enthusiasm of the office bearers of ISA Borivali, especially Dr. Yogen Bhatt, sir, Shilpa ma'am, Neelam, and Preeti, and all the members of branch of Borivali. They are very consistent in making CMEs and various programs regularly and back to back, making ISA a vibrant branch. I request all the other branches to take inspiration from them. I also request all the members of Maharashtra State Chapter ISA to take active participation in various activities held by Maharashtra State Chapter of ISA.
Sir, you are on mute. Dr. Avinash, sir, you are on mute.
Hello.
Varsha madam, please mute everyone except Avinash sir.
Hello.
Varsha madam, please mute everyone
Yes,
except
yes, ma'am.
Avinash sir.
Yeah, keep Avinash, sir.
There is a lot of disturbances and I was muted. Okay. Okay. Good evening, everyone. Respected President ISA National, Dr. Venkat Giri, sir, Dr. Meenakshi Sundaram, sir, and Dr. Pankaj Gupta, our President, Dr. Manisha Katikar, ma'am, all office bearers of Maharashtra State Chapter of ISA and ISA Borivali, all faculties, delegate, and my friend. I warmly welcome you all. First, we should really appreciate the energy and enthusiasm of the office bearers of ISA Borivali branch, particularly Yogen Bhatt sir, Dr. Shilpa madam, Neelam and Preeti, and all the members of ISA Borivali branch. They are very consistent in making CMEs and various programs regularly and back to back, making ISA Borivali a vibrant branch. I request all the other branches to take inspiration from them. I also request all the members to take active participation in various activities held by Maharashtra State Chapter of ISA. I congratulate to ISA Borivali branch and best wishes for this CME. I am not taking much time. Thank you for inviting me. Long live ISA. Thank you.
Thank you very much, Dr. Avinash Bhosle, sir. And a warm welcome once again to our national and state dignitaries. And along with the list of our PSA people, let us not forget to thank Dr. Avdut sir, Dr. Rao sir, Dr. Tendulkar sir for their precious input at every single CME that we have held so far. About the introduction to our today's topic, let me begin with Dr. Pankaj Gupta sir. He is absolutely not what he looks like. He is the biggest champion of private practitioners in the country today, as far as ISA is concerned. And his question last night was, why do you always talk about private practitioners? Why not include everybody? Let me try and answer your question, sir. We at ISA Borivali boast of over 80% of private practitioners in our group of over 200 plus members. Most of us work in small standalone nursing homes with limited infrastructure, where textbook conditions of optimization and OT requirements may not always be provided. Our aim has been to achieve academic excellence, get our knowledge scientifically, and enrich it with our practical experiences. We strive to find the best possible scientific solutions without compromising on patient safety. Now, today, about the science bit, we shall find out how we can use ropivacaine in our daily practice. It is not a new topic, but we shall try and present it in a modern way, in a new way. And also, we will also be having a talk on death on table. What do we do in private practice? How do we do it? And how we can deal with our conditions in a better manner. Death in an institute is very different from death in a small nursing home. How to deal with it is what we are going to find out. Along with science, we also have parallelic topics like diet and exercise today. All of us, most of us actually, have irregular callers. We have stray calls. We have middle of the night calls. There are no fixed hours for a private practitioner, unlike in a corporate. So we are on call 24/7 for 365 days in a year. Irregular diet and sleep habits take a toll on our health. So also sedentary lifestyle. We may appear as we are running around, but then there is not really much active running around. So let us see what our experts and our panelists have to offer today. With that, I hand over the podium to Dr. Manjusha Savir to continue this scientific session further. Thank you.
Hello, everyone. Can you all hear me?
Yes, madam.
Yeah. Here I am to welcome. Yeah. Here I am to introduce, welcome our guest faculties who are very, very honorable for all of us. And as you all know, after the heavy, tiring, toxic era of pandemic and a weekday of hard work, we have Saturday evening, which probably everyone could have thought of a cinema hall, a garden, or maybe in a mall. But here we have gathered together to spend few minutes with our honorable guest. And I'm very sure all of us are going to grab very, very precious jewels, which otherwise we could have anywhere else in this world. Yes, here we have Dr. Meenakshi Sundaram with us. He's an honorable president. And as you all, everybody knows, he is still working with the government institute, a government medical college. He's a professor since last 17 years. He is a Senate member of Tamil Nadu, Dr. MGR Medical University. And he is the one bridging the gap between anesthesiologists and the government. As we always think, we want somebody who can, convey all our issues and have the problem solving with the solutions from the government. Because though we try to tackle it at our personal front, hospital front, maybe our ISA front, but all we need is somebody to speak on behalf of us at the level of government. So he's the one who is always there for us, always who we can totally rely on. He is the one bridging 4 ISA branches in Tamil Nadu very actively and very efficiently.
Not only that, everybody knows that he has brought the radiology posting for the anesthesiology residents. That is now when we come across the cases and do our cases at the private nursing homes. Down the practice after 25 years, we know we get to read the radiological plates, your CT scans, MRI reports, and what we pick up is to read the report that has been written by the radiologist. I wish that time I feel whether I could have read the plates, the radiological plates of CT and MRI at that time on my own, which I do try, but not that perfectly. So he's the one bringing those things to introduction as well as to increase the efficiency of anesthesiologists in those things as well. He has been trying to bring the anesthesiology in the UG curriculum. Oh, wish I would have had that opportunity at that time, because yes, I landed up with an anesthesiology as my PG curriculum, just probably by nullifying all other factors, like all other curriculums. But had it been knowing about what anesthesiology is actually while being in the UG curriculum, I would have definitely chosen it by choice and happily. Yes. So he's the one trying to introduce that in the UG curriculum. That's so nice of you, sir. He is the one creating anesthesiology awareness through using the latest technology, print and visual medias, because that is the one where everybody can be easily and immediately, efficiently be introduced to our field, as well as to know the salient points of our field. He has conducted anesthesiology exhibitions for 15 days in the government medical college, not for the medical faculties, but it is for the public, which is like now also we are the ones, as everybody knows, and though we are trying to do how much ever we can to spread an awareness, we are always the ones who are parde ke piche. We are the padya magse kalakar. Okay. And he is the one who is trying to introduce us in public so as to have more and more awareness of our field for the people. He is the one conducting USG guided now block workshops in the government medical colleges. I wish I could have been the one learning it that way from the way it is being taught now in the government medical colleges, because that is where something that we can really have hands-on and get sure and be an expertise by trying everything that we can in our institutes. He is the one giving the medical students an opportunity to do that. He has delivered more than 500 lectures across the country in anesthesiology, helping the anesthesiologists in medical negligence cases. Yes, what more do we need? Another thing, yes, I'm very happy to say that he has a jewel in his crown. That jewel is, he's a Tamil poet. Wow, what to say. And he's been recognized as by the government as Tamil scholar. Oh, wow. We have such prestigious, honorable guest with us. I'm very sure we're all going to grab very, very precious words, which we are going to have with us, helping us in our practice, as well as to have us with us anytime that we need to have the guidance from him. I heartily welcome you, sir, on behalf of our ISA in this meeting. Welcome, Dr. Meenakshi Sundaram, sir. Another very prestigious guest of ours is Dr. Pankaj Gupta, whom I would like to introduce. I take an opportunity here. I'm really feeling honored to introduce you, sir, to our members. He's the one who is a national coordinator of ISA. He's the sub-editor, Journal of Anesthesia and Critical Care, where the case reports are being published on the pediatric section. He is right now been an expertise in pediatric anesthesiology, laparoscopies, ENT laser surgeries, joint replacement surgeries, and labor analgesia. That includes almost every branch of anesthesiology. He is an expert, renowned freelance consultant in anesthesiology in Nashik since 1991. He has been awarded as a trustee medical welfare trust of IMA Nashik. He is working as a president of ISA Nashik 2012-13. He is a president of IMA Nashik 2008 and 9. He is the vice president of West Zone ISA 2018-19. He's been working as a faculty at various national and state conferences. It's the best public awareness award that he has won of National ISA 2013. Yes, he's the BC Roy Award IMA 2016. The list seems to be never ending. That's so nice that you are here with us to help us out and guide us on so many practical things. He has received the first prize at JM session at JRC Coimbatore in 2018. Dr. Pankaj Gandhi is a National President Appreciation Award in 2013 and 2018. And probably his name was always been known to all of us because he was the one leading and conducting the Kumbh Mela disaster management at Nashik in 2003 and 2015. Wow, he has been an expert in disaster management and probably he's here with us to help us out to know how to manage the disaster when we come across the most and worst disaster that any of anesthesiologists can dream of having is the death on table. Yes, I welcome you, sir, Dr. Pankaj Gupta, for this meeting of our ISA, where all of us are eager to hear from you. Thank you so much. Over to members.
Yeah, Dr. Pankaj Gupta, sir. Dr. Pankaj Gupta, sir, can you share the slides? You are muted, sir. Sir, you are muted. Dr. Pankaj Gupta, sir, you are muted. You have to unmute yourself.
Madam, good evening. I am Dr. Meenakshi Sundaram. Right.
Yeah, hello, sir.
Good evening, sir.
Carry on, Dr. Pankaj Gupta, sir.
Hello, sir.
I am
Welcome.
Dr. Meenakshi Sundaram. And I thank ISA Borivali for this wonderful opportunity. And Dr. Manjusha Madam, who had the vigor to introduce me. अब हम तो पर्दे के पीछे नहीं, हम पर्दे के आगे हैं. And Dr. Pankaj Gupta will prove that. And the death on table is a very important topic. And in my parlance, if the patient dies on operation table, he may be having a painless death, but it will be painful for the anesthesiologist. Now, Dr. Pankaj Gupta will elaborate on that. Carry on, sir.
Thank you, Manjusha Madam, for a wonderful introduction. And I feel it's indeed a great honor for me to be speaking in front of such illustrious persons like our inspirational National President and my good friend Dr. Venkat Giri, sir, our dynamic ladies of Maharashtra, Dr. Manisha Katikar Madam, President, and Dr. Shilpa Tivaskar, both dynamic ladies of Maharashtra, our dynamic secretary, Dr. Avinash Bhosle, and of course, Dr. Meenakshi Sundaram, another good friend of mine, who has always been very active and been a great blessing to all of us in ISA. I feel in the last 6 to 7 years since I've been being the national coordinator of the Private Practitioners Forum, we have tried to do whatever best we can from the private practitioners' point of view. And I feel this was just another attempt which we thought that this is one topic which unfortunately is not discussed during our post-graduation. It is very rarely discussed in most conferences. And when I thought of this topic, I thought ki chalo I actually gave this topic to someone to present, but then I was not happy with the way it went around. So I decided to prepare this topic for myself, and I'm fortunate to be sharing whatever views and thoughts I had. Of course, all the views expressed here are my own. And because if you go on the net and you try to search, you do get some matter, but not something which is really practically possible. So I'll try to discuss as much as practical topics as practically as I can. And coming to my topic per se, anesthesia death by definition is actually defined as death occurring within 24 hours of administering anesthesia due to causes attributable to anesthesia. This is actually quite a controversial thing to say, because most of us feel that once the patient's out from the table and in the post-operative room, our job is done. But no, the definition says that, so it remains a little bit of a controversy for us actually. The incidence is something like 0.5 to 0.8 die per 1 lakh operations. And mainly it has been found that in emergency surgery, the incidence is 80% out of the 1 in 30 per lakh. It has been found that patients of ASA grade 3 have 1.8% mortality rate as compared to 9.4% in 9.4% in grade 5 patients. The good thing is cardiac arrest in an operation theatre is reversible almost 80 to 90% of the times. And these are various incidences which have been described. That, you know, of course, these figures are all from mainly UK. In India, it is very difficult to really decide what exactly the incidence may be. I would like to make it simple. Okay. First of all, the types of anesthesia, coming to a reality check in our situation, it is not very easy to exactly know what happens in the operation theatre, because an on-table death is like death in police custody, where the patient is all alone. There is no one to help him, and nobody knows the exact cause of death except the operating team, that is the surgeon and the anesthetist. So it becomes very difficult for anyone to really, for the relatives or anyone else to know, other than the people present in the OT, what may be the cause. The type of anesthesia death related maybe during anesthesia, but unrelated to the anesthesia, and of course as a direct cause of anesthesia. I'll just go through some of the important things, like, you know, when the patient itself is so serious or having a very major disease, or when this patient has a serious disorder like valvular heart diseases or undiagnosed lesions like coronary artery disease, patient may be in surgical shock and in exhaustion, or there is a surgical accident such as a large vessel damage or aneurysm bursting. These are all deaths during administration, but unrelated to our cause. Whereas deaths due to administration of anesthesia directly can be because of, we all know how intubation can be very treacherous and dangerous for some of us if we are not really experienced and we have not taken all the precautions for a difficult intubation. Technical mishaps are known, where equipment failure, something may have gone wrong with the workstation or the Boyle's machine. Sometimes the wrong drug may have been administered because of wrong labeling, or there may be oxygen failure and only nitrous may be going to the patient. Or sometimes the anesthesia agent mishaps such as tilting of the vaporizer, these sort of incidents can happen in the operation theatre. And of course, for various reasons, there can be acute cardiac respiratory complications on table, either because of the anesthesia drugs or whatever diseases the patient may have, or even an acute neurogenic cardiovascular failure. In private practice, in freelance, it becomes a very, very difficult situation to be in, because it's always a one-man show. The PPF safety guidelines may not have been followed. You all might be aware that about 3 years back, we came out with the safety guidelines which are religiously to be followed. And recently, I came across some cases where these PPF guidelines have been taken over, have been examined by the Supreme Court, and they have mentioned it in the rulings that ISA has come out with the safety guidelines, and these guidelines were not followed in such and such nursing home. So please request to all the members, please follow all the safety guidelines that have been mentioned on our ISA website. Stress in private practice is obviously very high, because many times we have very tight schedules, overlapping cases, too many cases. Many times we are overworked, we have night cases, emergencies. Some of us may not be updated on various guidelines. And of course, the fear of competition sometimes makes us unnecessarily daring in an occasional situation. These are the guidelines which are there on our website for anyone can download. Now, unfortunately, something has happened. What is the first thing that we should do as an anesthetist? Call for immediate help. Stop or complete the surgery. Ask the surgeon to close the wound. Do the dressing. Do not leave anything in the wound. Always remove all the tubing from the patient's body. Note the amount of urine in the bag. take back any prescription if at all you have sent the relatives of the patient, because actually this is ideally not to be done, but in private nursing homes, it usually does happen that the relative has been sent out to get some emergency replacement. So please do not do that in the first place, but if you have, try to collect back the prescription. And before you actually inform the relatives, always better to inform the relative that the patient is a bit serious or is collapsing, rather than directly going out and declaring that the patient is dead. And it's always better to shift the patient from the operation theater rather than inform when the patient is still in the OT. See, obviously, I'm going to just discuss things taking into consideration that the patient has died on table and what is to be done after that. I will not discuss what precautions we may have taken or something of that sort, because that we are all aware of and it has been discussed on various forums. Some of the precautions we take before informing the police, obviously we have to inform the police, is preserve all the broken ampules and syringes in the OT as it is. Do not clear the OT. Complete all relevant documents chronologically, like the PSC notes, the pre-op fitness records, the physician notes, the anesthesia records, the nursing notes, the resuscitation notes, along with the timing, what time you have given what drug, and most important, tallying the notes of all the concerned doctors. You may have called a physician, you may have involved a cardiologist, the surgeon must have helped you in the CPR. So all those things have to be specifically mentioned in the notes. While informing the police, it's always better to dial 100 because all such calls are recorded. After informing the police about the incident, always better to involve the local IMA, the local ISA, or any such help organizations which may be present in your city. I can understand this. Every city has its own set of functioning. So at least this is what I would do in Nasik. I would definitely involve the IMA and ISA. And if you feel that something is really wrong, and ask for medical legal help. I always feel that the most important person in such a situation where the anesthetist is alone, I feel another colleague anesthetist should immediately be called and preferably be present when the situation to help in case it has been a high risk case. And let him also, if he comes, once the incident has happened, let him check the patient, let him check all the equipment. And if you find that your suspicion of an equipment failure is there, or malfunctioning of the workstation or something of that sort, then please isolate that equipment and let it be kept in the OT and for a formal examination which can be undertaken at a later stage. In institutes, obviously you inform the head of institute and he takes care of everything else. But in freelance, we have to take care of everything. As I said, inform the police, colleagues, bouncers. Sometimes these days I find for a lot of hospitals employing bouncers, which can be a little controversial. And at such times, I feel it's always good if you or the surgeon happens to know the relatives of the patient, or fortunately for you, if at least one of the relative of the patient is a doctor, please involve him and ask him to come over. And if you are known or you have good relations with the local politician, and if you feel he is a good person, definitely involve him. We should always remember our liabilities for before every case, not just if something like that has happened. Always go through and confirm whether you had properly examined and investigated the patient properly. Was informed consent taken and suitable type of anesthesia given? Was anesthesia administered and operation performed with reasonable skill and care? Were suitable and adequate arrangements made before the operation to deal with any emergency? Were suitable steps taken to resuscitate the patient? I feel this should be we should go through this before every case that we undertake. Handling the situation now can be very treacherous for us, the surgeon, and for us. As I'm again and again saying, call your friends, colleagues, call for help, have a very cool attitude, do not panic. I have always believed that we are the captain of the ship in the operation theater, and if the anesthetist panics, then it is all mayhem in the operation theater. I recently heard from a surgeon that anesthetist induced the patient arrested. Unfortunately, even the anesthetist fell down in a state of shock. The poor surgeon had to intubate the patient. He was resuscitating not just the patient, even the anesthetist, fortunately, who came out. So I feel most important thing is don't panic in such a situation. It's very, very important, I feel. Review the sequence of events with the team that is there in the operation theater. Obviously, at this time, there should be no blame game between you and the surgeon. The documentation is the most vital thing that you have to foresee. Confirm that there are no discrepancies in the records. And most important, the junior staff should not be allowed to go out and talk to any of the relatives, because their loose talk can unfortunately turn out to be very dangerous for us. Now, what are the problems we are going to face? Immediately breaking the news to the relatives, facing the questions or ire of the relatives. There can be a mob violence. Police inquiry has to be handled very meticulously. Medical legal issues we should be aware of. And delayed, we know that it can be very damaging to our reputation, loss of self-confidence, stress, compensation amount. All these things come later on in the situation. Coming to the first topic, that is breaking the news. As a freelancer, immediately cancel all your further appointments. Most of us have lists of cases, so please cancel all your further appointments. When the surgeon is talking to the relatives, always see that you are accompanying the surgeon. Maintain your poise and be compassionate with the relatives. Inform the incident in a private room where only the close relatives are present. Try to make the relatives comfortable and allow them to ask questions, because obviously they have lost a near and dear one. And as far as possible, don't hide facts. It's always sometimes good to be truthful to the patient, what exactly may have happened. And of course, at the same time, be ready for extreme action. As I'm again and again repeating a few points, because I feel the surgeon and anesthetist should obviously be on the same page. Transparency is very good with the relatives. Of course, that doesn't mean you have to tell everything that has happened in the operation theater. All queries have to be firmly answered. You have to show a genuine concern, and try to avoid medical jargon when you're discussing things with the relatives. And all procedure related deaths warrant further investigation and probably postmortem. Relatives should be given an opportunity to pay their last rites or last respects in a quite segregated area. If possible, if you don't have a proper ICU, try to shift the patient to a temporary post-op room, and it makes our job a little easier. As I mentioned, if you know any doctor relative, please ask him to be present. Inform the relative, inform the local politician or the influential Samaritan if possible. Presence of police may help in keeping the relatives calm, but sometimes it can backfire. The relatives might think that because you have done something wrong, you have informed the police. The moment you think there may be mob violence, keep looking around for some mischief mongers who sometimes take advantage of the situation. I've always believed that every operation theater should display the telephone numbers of the local police station, the commissioner of police, the local IMA, ISA office bearers, and if required, bouncers. Always informing the police is very important, especially when you don't know the cause of death, or when you do know the cause, but you to let the relative know that we are not hiding any facts. It makes sense to inform the police. And we all know that it's obviously compulsory to inform the police in any death related linked to abortions, any death on table, any death within 24 hours post-operative, death related to accidents or violence, all this related to tubal sterilizations, and when there is allegations of medical mismanagement. At such time, the police come, they perform a panchnama. Remember that you may be questioned, answer smartly and confidently. Information, as far as possible, should always be in writing and written acknowledgement obtained. But always remember, surgeon is the first point of contact. But for any queries, we have to be always present with the anesthetist. I know of a situation where the anesthetist left the surgeon when such an incident happened, and unfortunately, he had to face the consequences later on. Later on, we are obviously going to be involved medico-legally, because the relatives are going to consider it as a malpractice and death-related procedure. Obviously, they consider it as negligence. It is up to the doctor to explain the sequence of events. And post-mortem definitely is what we are always going to advise. Anytime that is helpful to us in many other ways. Of course, a lot depends on surgeon's influence and relations with the patient's relatives, and the final outcome varies. See, obviously, every death on table the management will differ depending on the surgeon, the anesthetist, the local situations, small city, large city, metro city. So we have to be aware of what all can happen. The reason why I was insisting on a postmortem, because in one of the Karnataka High Court rulings on DOT, they held that in the absence of postmortem or histopathology, the possibility of other causes of death cannot be ruled out. So therefore, death on operation table does not mean that the doctors have been rash or have been negligent. So always insist on a postmortem, because many times it is useful to us. The documents, if you have confirmed and completed, check that they are complete. Always verify that nothing adverse has been mentioned. Check the date, timings, compare the notes, paginate the papers, take the signature on receipt. And if you have time, try to recheck the documents by a medical legal consultant or some senior anesthetist around. Always confirm that the medical records are totally complete with respect to everything that we always do, including the past history, family history, the diagnostic aids which were used, the physical examinations, the date and hour of consultation, the clinical impressions, the progressive notes, and also confirm that all the preoperative instructions that were given to the patient were religiously followed. If the patient is known to have medical diseases, just confirm that the complications have not been missed by you in the PAC. If you find that the patient has not been cooperative in the while following up with the surgeon or following up with us, or if he has failed in following advice, or whether he has not kept appointments, just make a note of it in the case paper. You never know, it might just help you in the long run in case your case goes to court and your lawyer can do something about it. Documentation is very, very important, because it is the only way which is going to save you in the long run, because poor records means poor defense, no records means no defense. In some of the cases that I regarding anesthesia related, there were contradictory statements about the cause of arrest between the surgeon and the anesthetist, and also there was no record of continuous monitoring of pulse, blood pressure, which is so important in our day-to-day practice. So obviously this case went against the anesthetist. In another case, there were two anesthesia records with different times of arrest. I don't know how the anesthetist would do such a folly, but probably this was quite some time back, and the height was the name of the anesthetist were not written in the record. So obviously the hospital was held liable for deficiency of service. As doctors, we should all know what IPC 304A means. And this is on the only thing which is mainly applicable to us. That is causing death by negligence. Whoever causes the death of any person by doing any rash or negligent act, not amounting to culpable homicide, shall be punished with imprisonment of either description for a term which may extend to 2 years, or with fine, or both. So we should all know that in case of medical negligence, they all come under 304A. 304A Part B, it usually is implied for those cases where there is an intention to cause death. Mainly the dowry related deaths come under 304B. But some smart policeman who wants to take us for a ride, sometimes they do this. So remember that 304A is what is applicable to us. Recently, on 2nd October 2021, the National Medical Commission has come out with a proper directive how death on table, or how the Ethical and Medical Registration Board should take care of such a situation. Because in the past, there were various boards prepared, but now this is what has come recently. It is suggested that every district should have a district medical council board. There should be every state medical council board. A doctor cannot be arrested in a routine manner. This is what has specifically been told by the NMC Commission. There have been a lot of situations where doctors have been unnecessarily been arrested, and taken. We have been taken for a ride. So this information I feel is very important. The District Medical Council has been asked to conduct a preliminary inquiry for 2 weeks. It's a time-bound inquiry. They are supposed to refer this to the State Medical Board, who, if they feel that the District Council Board has not done a proper job, they can involve some more specialist members and again work on this, and they have to decide within 2 weeks whether to endorse or reject the District Medical Council that has come out with whatever ruling, either for or against the doctor. Now, can a doctor be arrested? It has been very clearly mentioned by the NMC that just allegation is not enough. Arrest is possible only if the negligence is very, very evident, or when they feel that the investigation may be helped, or the doctor may not be cooperative, or he may not be making himself available for further questioning. These are the only two incidences where a doctor can be arrested. Even then, if the investigating agency has to place all the position in front of the superintendent of police or the deputy commissioner of police, only under their instructions they can arrest a doctor. So be assured that no doctor can be arrested for a death on table unless these two criteria are there. Of course, now that a death has happened, we have to inform our medical indemnity insurance company. We all know it is very vital to have adequate insurance cover. These days, the lawyers itself, they suggest that if the case can be settled outside court, they themselves do it for you. That's why I feel having a proper indemnity with a good company is very important. I feel very happy that ISA National has taken this initiative, and I feel all of us should get registered now with cover you that has been endorsed by the National ISA. Long-term defamation obviously is very damaging for all of us. It lowers our moral, intellectual character. Self-esteem is very low for our profession. Recently, I was reading up about an article about how 28% of all anesthetists are found to be depressed, and suicidal tendency is pretty high. I mean, the incidence was pretty high in that article that I read. Once this situation happens, we are always in a big state of shock, guilt, anger. We have nervous breakdowns. There are we feel very, very low in our confidence. This is where good friends, I feel, are very important. I have always said that the best friend of any anesthetist is another anesthetist from the same city. Please do not take any other cases after this situation has happened. Start practice only after you have totally regained your confidence and self-esteem. Last but not the least, stop thinking about this constantly. Try to take a break. Go out with your family. Learn the lesson it teaches. Most important, because we always keep saying anesthesia is never minor, though the surgery may be. As I already mentioned, ISA has already laid down safe guidelines. So please follow them, download them from the website, make them available to your surgeons, equip your operation theaters to the best of way we can. I would look at it this way, that in 1995, when we came under the CPA, Consumer Protection Act, maybe we got a chance to improve our operation theaters. And COVID probably helped us in bringing more workstations in the country after we started insisting that closed circuit is absolutely essential for all our patients. As I already mentioned, ISA encourages indemnity in medical legal protection. And I feel now in the future, we should start thinking of whether we should be limiting our working hours per week, just as it is done abroad, rather than working continuously 24 hours a day. In my initial days, when I worked, 48 hours continuously almost. So it is very difficult to say no, initial days at least, but I feel the sooner in life and in our practice, when we learn to say no, it becomes much easier for us. I feel trained personnel in OT is, I feel, a need of the hour, and in future, all of us, we should insist on this. My take-home message is going to be obviously proper knowledge communication is very, very vital and important. Documentation, there is no substitute. You have to document everything properly. These days, CCTV consent is being taken by a lot of surgeons, and even some anesthetists can do it, mainly in institutes. But it can be a little controversial. Adequate medical, legal, and legal backup is absolute must. Adequate indemnity insurance is the need of the hour. Strong peer support of friends, colleagues, IMA, ISA, local goodwill of politicians and the society. Whatever role you have as a local good Samaritan, yourself as an anesthetist helps a long way in overcoming such crises. At such times, expect the unexpected. You don't know, because there are going to be ethical issues and legal issues in the long term. Try to do things as a matter of habit and not just out of fear of law. I feel these golden rules of anesthesia, every one of us should follow. A stands for assessment of the patient. N stands for nil by mouth. A stands for attention and alertness to patient and monitors. E stands for evaluation of drugs, instruments, equipment. S stands for a suction which is working. T stands for a table which is adjustable. H stands for having an open vein for every surgery. E stands for examining vitals like pulse, blood pressure, ECG, oxygen saturation, EtCO2, etc. S stands for someone to help. I is for the intubation equipment, and A is for the airway trolley. I thank you for your patient listening. I'm sure the discussion is going to continue in the panels, because this is a topic I feel which all of us hope we never face in our life situation. But statistics show that usually at least once in a lifetime, every anesthetist goes through such a situation. I thank you all for your patient listening, and I hope we can continue with the discussion. Thank you, everyone.
Dr. Rao sir, to you, and Dr. Yeah, Meenakshi Sundaram sir.
Hello. Dr. Meenakshi Sundaram.
Yeah, sir.
Yes, sir. Yeah, Dr.
Hello.
Meenakshi.
Am I audible?
Yes, sir.
Yeah, you are audible, sir.
Yeah. It is a wonderful presentation he has given. In a nutshell, he has given once a table on death occurs, there should not be any controversy between the surgeon and the anesthesiologist. There should be a clear coordination with the surgical team, and we should be very open-ended communication we have to maintain, and necessarily we have to inform the police authorities. And he said it is always better to contact 100 because it will be recorded. And even I have seen a message at the time of handing over the body, it could be even video recorded. That way, that we have to have a difference of opinion in that, because at the time, if you take a videograph, at least some patients will be annoyed. So the man on the spot will be the ideal judge. So that videographing is to be decided according to the each and every individual merit. And now he has opened up our minds regarding death on table. Now it is open for the audience to put their questions and their suggestions.
Dr. Rao sir, can we have the panel, please? Meanwhile, welcome Dr. Kamdar sir. You had raised your hand. Do you want to say something? Sir, you are on mute. Dr. Kamdar sir, you are on mute.
Can you hear me?
Yes, sir.
Yeah. See, I am Dr. Kamdar. I have been practicing for quite some time, and as the speaker said, that there is no anesthetist who has not come across a death on the table. I fully agree with that. There are certain observations and some points I would like to specify. First thing is that don't be in hurry to call the police. What I feel is that once you should talk to the relatives, take them in the confidence, and tell them.
Sir, mute झालात तुम्ही. Sir, you are on mute. Dr. Kamdar sir, you are on mute. Kamdar sir, mute झालात. Dr. Kamdar sir, you have to unmute yourself.
One minute.
Varsha madam, when you're muting everyone, see to it that the speaker is unmuted.
Yes, yes.
Yeah, Kamdar sir.
Hello, am I audible?
Meantime, Dr. Rajesh Rao sir, can you take over the panel, please?
Hello.
Hello. Yes, yes, Rao sir.
Am I audible?
Yes, audible. Maybe you can increase the volume a bit.
Okay, that was a very good talk. There are a few questions which I would like to ask. This is something like, does this DOT consent? A lot of people, when they present cases, high risk cases, they say that DOT consent was taken. is it really valid, DOT consent?
You want me to answer that, Rajesh sir? Hello.
So-called DOT consent.
Yeah. Sir, if you can answer.
Yeah. See, a consent is become challengeable today in court of law. Recently, there was a ruling where, going through the history of consent, maybe 20-25 years back, even people like me were not taking consent in private practice. Then it gradually started taking a proper surgical consent was only being taken. In the last 8 to 10 years now, anesthesia specific consent has come into league. After that, now what has come is, I feel 6-8 months back, there was a ruling by the Supreme Court saying that you have to have a specific consent for every surgery. And so every day the law keeps changing for us. So it has made things a little bit difficult. Regarding death on table consent, definitely informs, makes the relatives aware and even the patient aware that he is going through something which can be very dangerous. And he may have the surgeon and the anesthetist are dealing with a life and death situation. So taking a duty consent definitely is valid in the court of law. But if unfortunately the judge sitting there has something else, then it becomes a little difficult for us. But definitely you have to inform the patient that there is as I mentioned, ASA 3 has a 3.4% of DOT, whereas an ASA 5 has 9.4% of having a death on table. So you have to take the death on table consent, and it is valid as of now. Of course, the recent ruling has just mentioned that for every surgeon's surgery now, probably you should take a separate handwritten consent for every surgery, which how feasible it is very difficult to decide.
Now there is a difference between an ASA 1 patient and an ASA 3, 4, 5 patient. 3, 4, 5 patient is very easy to explain to the relatives that is a very high risk candidate for surgery and anesthesia. And sometimes, this death on table becomes acceptable. But in case of an ASA 1 patient or ASA 2 patient, if this thing happens, how to go about it?
Yeah, that is exactly what I discussed in my presentation. Yeah. This is exactly the way, because unfortunately, when the relatives are aware that the patient is serious, then it is become little better from our point. But if ASA grade 1 patient dying, there are so many instances. Then this is what my modus operandi would be what I presented exactly.
So this leads to another question: how to decide which patient to do where? Like there are a lot of there which do cases of.
I know. See, somehow I'll tell you all these Supreme Court judge rulings that have been coming have not been very pro-doctor friendly. There was a ruling recently, some patient was taken up for hysterectomy in a nursing home, and the patient had some complication on table and was ventilated for 8 to 10 hours post-op. Unfortunately, that patient had to be then shifted to another nursing home and the patient died. So the case went against the surgeon and the anesthetist, saying that, nursing home, why you do not have a ventilator setup? So does it mean that you should have a nursing home without an ICU? It is something similar to what problem we are facing regarding our anesthesia and MRI centers or in diagnostic centers, where the Supreme Court has given a ruling that you should give anesthesia only when there is an ICU backup in such centers. Now, how many MRI centers or how many CT scan centers have an ICU backup? So these things are still, they are in a gray zone. And depending on the situation, the case will be with us or go against us.
Then regarding this medical legal complaint versus death certificate, there are incidences where the surgeon anesthetist and his
Dr. Pankaj sir, I am Dr. Meenakshi Sundaram. Can I intervene?
Yes, sir. I feel in fact Rajesh was asking a question and it got cut.
See,
the audio just went.
Yeah, actually, the Supreme Court has given rulings. See, mostly the Supreme Court rulings are in favor of doctors. You said that it is against doctors. But what I want to say, as there is no prescribed fixed law for medical negligence, it varies from judge to judge depending upon their mentality. So it means even all the nursing homes for MRI and all scan centers, they cannot have an ICU. But see, we should have a backup. Backup means like hand ventilation. But see, and even though Supreme Court says that ventilator is mandatory, we have to also analyze ventilator is mandatory for the cases. If it is not so, we have to have a prayer plan because it is a life or death case. So I feel the lower courts are against doctors in most of the judgments, and the higher court and the Supreme Court is definitely in favor of doctors. And recently, they have passed a judgment also. You cannot expect the doctors to lie by the side of you to take care of you. So again, the judgment varies means it depends upon the mentality of the judge. So we have to be very careful with that. And whenever we do, we should have a backup plan. If in case if there is a mishap, how we are going to handle it. And as you say, the recording is to be perfect. Then we can escape from the medical negligence. But morally, if the infrastructure is inadequate, we have to refuse the case.
Yes, sir. That is very obvious, sir. That's why I've been harping for the last few years on just what ISA has been recommending regarding the minimal essentials in OT, the drugs in OT, and the minimum standard that we should follow.
Yes, sir. For that, many of the hospitals now are taking consent. Like they are taking consent from anesthesiologists. They are also taking consent from the ambulance services, ICU services, that they will provide ambulance services or ICU services if they need. Like that, consents are taken now. They are taking for hospital registrations. Even they don't have these facilities.
There is one question in the chat box. Like in such a situation, you call for help. So what is the liability of the other anesthetist friend who has come to help you in case of?
Yeah, that I will answer. See, what you are asking, the second person is called as a good Samaritan. So the good Samaritan role says he will not be liable for any mishap if he belongs to the same specialty. Like one anesthetist calling the another anesthetist, then definitely he will not be liable. The first person is liable for that. But in surgery, a little bit difference is there. In case during hysterectomy, if the obstetrician calls a urologist for repairing the injury to the ureter or to take care of the ureters, and if something happens with that, then the urologist is responsible. But as we are anesthesia society, if the second anesthetist goes, definitely the good Samaritan role helps. He will not be liable. So I request all the anesthesiologists to help their colleagues in times of need. Thank you.
And one question regarding in the case of eventuality, which is a better option, medico-legal police complaint, or if the surgeon or the physician friend is willing to give the death certificate and the patient's relatives are also okay with it?
If the surgeon or physician is very confident of the exact cause of death, only then he can definitely give a death certificate. But in present situation, many times they avoid giving a death certificate.
Yes.
Because that is why postmortem becomes important. There have been instances like the Karnataka case that I mentioned, like the patient had some other problem and it was found on table later on during the postmortem. They found that he had some severe cardiac problem. So probably the case was a little diluted because of that situation. So that's why I will always insist on having a postmortem as far as possible, unless the physician is very sure of the exact cause of death, or the surgeon that way. So death certificate they will only give if they are 101% sure of the exact cause.
So the death on table should be declared at that time, or is it better to shift the patient to the ward or the ICU and then after some time, considering the situation, then declare?
Definitely better to shift the patient outside the OT into the ICU or postoperative room and finish all these other documentation and other things that I mentioned, and only then declare after about some time. Definitely don't make a hurry to inform the police, as even even sir said that don't make a hurry. Dr.
Okay.
Kamdar was talking about it actually.
There is one more question. What is the role of AED versus standard defibrillator? As in case of AED, we have to wait for the rhythm to worsen to VA for VT, and then AED will deliver the shock.
Sir, once again,
Yeah.
I am Dr. Meenakshi Sundaram. I want to add why we are certifying the patient in ICU means if you certify it inside the theater, it means it is death within the four walls that lead to suspicious death. So
Okay.
routinely, the suspicious death is to be investigated by the RDO, the revenue authorities. So that is the reason why it is always better to certify it outside the theater. Then it will be only medical and medical negligence. Unnecessarily, the third party will not enter. So we have to keep it in mind.
Okay.
Thank
Again, what is the role of AED versus standard defibrillator? As in case of AED, we have to wait for the rhythm to worsen, and then AED will deliver the shock. This is a question by Dr. Samir Deshpande.
It's a very tricky question. Whether we have to wait or not, it depends upon the clinical situation. How we can wait for the rhythm to worsen, because before worsening only we have to act. So when the patient is dying, at that particular point of time, whatever treatment is needed, we have to deliver. We cannot
Right.
wait for the rhythm to worsen.
Okay. Does filing an FI with police early help us? Question by Dr. Sonal Pandya.
It will depend on the situation again. What exactly has happened and what has happened. But as I said, don't make a hurry to inform the police. Take some time off. See the situation, gauge the situation, gauge the relatives, how they are going to act and react, and only then, if the surgeon also and you both decide, then it's better to inform the police.
There is one section by Dr. Rupali. The guidelines for arrest of doctors should be handed over to the police, all police stations, as their medical legal knowledge is sufficient.
Absolutely.
Absolutely.
There is one more case which I did not mention, on Martin D'Souza case, where the the Boehm's law and Les Ipsa, all those things have been specifically mentioned in that case. And of course, the ruling that I mentioned, the National Medical Commission, they have given only two indications where the doctor can be arrested. So this National Medical Commission report, if you want, I can forward it to you. I do have a copy of that. In fact, I have forwarded on a lot of PPF groups also. So it is very clear now. Only thing is, how many cities are already having National Medical Commission? I'm not aware. Like the civil surgeon, if you have a medical college, the forensic department, HOD, a committee of 3 has to be formed in every city. The latest procedure that has been going on everywhere, I'm not very sure, because this ruling came very recently on October 2nd, 2021. Because I talked to the National IMA president, he said that it is being applied in quite a few places. Only now the people are becoming aware of it. So having a copy of that Martin D'Souza case and also this National Medical Commission in every nursing home definitely is very useful, I feel.
But definitely that is a good suggestion. We have to educate the policemen. So
Yes.
it could be done. It could be done in an informal way. So they can be called for a IMA meeting, or they can be the SP can be the chief guest. At the time, we have to inform and hand over the copy to the SP and request him to circulate it to all the police stations. Definitely, that is needed, because no inspector who is the investigating officer, IO, they are not aware of handling the arrest of doctors. So that is vital. It should be done in an informal way, palatable way.
In fact, you reminded me of something, sir, which I would like to share here. When we came out with this minimum monitoring standards in Nasik ISA, this was I feel in 2013. So I informed the Commissioner of Police to come as the chief guest on Doctor's Day, and I unfurled those minimum standards at his hands. Initially, he was asking me, "Why are you calling me a Commissioner of Police for such a function?" No, sir, because that we had planned a CPR training for the police personnel in Nasik. And then at the end of it, I was surprised he took a copy of those minimum standards with him. I was like, "Sir, why are you taking with you?" He said, "No, it's a good standard for me." So this is, I feel, the best way. Involve the police department in as many activities of ISA, or at least one activity in the year, and let him know all these things. It makes a big difference that way.
Recently, the reverse was there. Reverse was there in Mumbai suburb. Last few months, the local police stations are calling the local hospital owners, and they're interacting with them themselves, and they are trying to emphasize that we are there to help you. Help will reach you in 7 minutes. You have to just call 100 and we'll be ready to help you. I think it's a good initiative from their part.
Yeah, good to hear that. This has been done in Bombay.
Mumbai,
In which
Mumbai.
part? Which part of Mumbai?
The northern suburbs.
Okay, great.
This last month they had 3-4 meetings in the local like Borivali, Kandivali, Malar. They have been calling they have a WhatsApp group, police station, local police station, and the nursing homes. So that's quite interactive.
Yeah. Yeah, I feel as a doctor, we have to have a good lawyer as a friend, a good policeman as a friend, and a good local politician as a friend. It definitely helps a lot.
See, somebody asked about in case of a surgical complication, how much anesthetist will get affected. See, surgery is always a teamwork, but it is a clear-cut negligence on the part of the surgeon, like cutting the aorta, cutting the ureter. The anesthetist will not be responsible for that. But anyway, case will be filed against him. He has to go and defend. At the time, we are not supposed to demarcate our area. We have to say, as far as anesthesia is concerned, there was no complication. That way they can come out. So the surgical complication per se, anesthetist will not be affected. Same way, the surgeon will also defend in anesthesia. That is, before making an incision, if the patient dies, then the anesthetist will be held responsible. But as far as the negligence case is concerned, it is always better we work and defend as a team, not individually.
Any more questions?
Rao sir, I think Dr. Kamdar sir wants to say something.
Yeah, he's. Kamdar sir.
Yes.
You want to say something, sir?
Yeah.
Please do.
Actually, there are a lot of things to comment. As I said first, that don't be in a hurry to call the police. First, to convince the relatives what is the importance of calling the police and why we are calling the police. It is not that we are going against them or something. That is one thing. Second thing, relatives will always against asking for PM. They will say, okay, please give us the certificate. So that time you must tell them that we would like to give the certificate, but it is not. It is in interest of the doctors and the relatives not to give certificate, because the circumstances in which the death has occurred, it is always better to call the police and let the police decide. If police decides, and police will ask the relatives, and if they are convinced, police will take Panchanama and ask them to hand it over without doing postmortem. It is not necessary that every case that happens or death happens on the table need not be, one need not do the postmortem. Second thing, please remember, if the postmortem is done, you are bound to get call from the person, doctor who is doing postmortem and asking you for something or the other. Please do not oblige them. Please do not attend their calls. I'm telling you, that will be a big problem on the part of the anesthetist. Third thing, ultimately, I don't wish, but if the case goes to the court, it is the paperwork which is there will speak in the court. However sincere you may be or however negligent you may be, but ultimately what the paper has, what we have mentioned in the paper, what notes we have done, that is going to speak. And that is why don't be in hurry to write the notes immediately. Your first important is to take care of the patient as early as possible. Then sit down, be cool, think properly, and then write. And when you are writing, don't do any check cancellation or writing one about the other thing, and all those things will definitely create a doubt in the mind of a court. There is another thing. And second thing, I don't know whether I should say or not, but in my career, I have fought 6 of my colleagues who had these problems and who were taken for consumers court, and I have fought for them. and only the paperwork which was there has helped us. Out of 6, at least 5 cases we have come out and we have won. So what I am trying to say that whenever something happens, it has happened. What you have to prove is that you were not negligent. We have full sympathy with the patient. We have to convince the relatives that yes, it has happened. It's an unfortunate thing, and we have all the sympathies. But that does not mean that there was a negligence on the part of the anesthetist. That one thing one should remember. And second thing, for God's sake, the speaker said that you call the politician. For God's sake, remain away from the politicians. I am telling you, instead of getting help, you are going to be in trouble. So please remain away from that. These are the few points that I wanted to bring to your notice. Thank you.
So just a reaction to the politicians part. Fortunately, in Nasik, I have a good relation with the local politicians. So I know who will stand by me. And I found that they are very good spokespersons at such times, the local corporator or something. That happened quite a few times even in Nasik, where at some hospital there has been an incident. And the corporator or the the local politician has definitely helped us out in this situation. And fortunately, we had 2-3 doctors also who were local politicians. So that's why I said, depending on the situation, and if you know the politician well, only then involve him. Otherwise, don't.
Actually, all the things which happen are late repercussions. What we are worried most is the immediate effect, which is the mob. We have had incidences where the hospitals have been broken and they had to shut down. So at that time, what we think, and anybody thinks in this situation, is how to manage the mob. So I think the best way to manage is to get the police and your known local politicians available, get their help, because they are the ones who can manage this.
Yeah. And regarding managing mobs,
Mob is the most important. I mean, whatever happens is later on, but immediate is that mob mentality who will come, they will hit the doctor, they will vandalize the hospital, the property, and once that happens, then so before that happens, I think better to call the police and get the situation in control.
Yeah, many times the police reaches late. So now what IMA Pune has done, even IMA Nasik has followed the same thing. We have formed a group of, rather hired a group of bouncers that in case of any situation, they are informed and immediately they are rushed to the situation, rushed to the spot. So this is going on in quite a few cities in the country now, that people have started employing bouncers by the local IMA, and these are helping in the long run, probably that way.
Yeah, and plus we are association like Association Medical Consultants. We have a task force group where the message goes into the group immediately, and immediately within 5-10 minutes or so, the nearby doctors, consultant friends, they come. So 5-10 doctors are there. So that also helps in easing the tension.
Yes, perfect.
Yes, you are very lucky, Dr. Gupta, that you have got a good politicians and you have got good relations with politicians. But everybody is not as lucky as you are. And second thing I wanted to bring to your notice is that one must give the bill. Whatever is the normal bill, you must hand it over to the relatives. Don't insist to pay them immediately, but you must do it. Don't do it free. Just because something has gone wrong, don't cancel the bill. You must give the bill and tell them that this is the bill. Let them give or let them give afterwards. But you must give it. If you do free, it is read the other way. That because something is wrong, you are not taking the bill. So please remember that.
Absolutely, sir. One more thing I would like to say: if there are some surgeons who go do an out-of-court settlement, it has happened in Nasik long back. The surgeon went and paid the relatives, and after any year, the relatives filed a counter complaint. The good thing about indemnity insurance today is the lawyers do it for you. So always go through the official legal process. Even if you have to do an out-of-court settlement, don't do it personally.
Yes.
Very important.
Yeah, thank you, everybody. Can we go on to the next talk, Dr. Rajesh Rao, sir?
Yeah, I think it's done. Thank you very much, Dr. Pankaj Gupta, sir. That was an excellent, enlightening talk. And it was a great honor to interact with you. Thank you. Thank you very much.
Thank you. Thank you. Thank you, everyone.
Dr. Manisha Sangve, madam, can you introduce our next speaker, Dr. Shilpa Joshi?
Yes, sure.
Can we have the
I
slide,
think,
Dr. Varsha, madam?
Yes,
yeah.
ma'am. Sharing.
Yeah, after listening to this important but yet very scary topic, I'm very sure everyone's head must be feeling heavy and the throat's very dry and must be wanting to have a hot samosa or at least a sip of masala chai. But yeah, I'm very sorry we cannot provide you that. But here I am with me, Dr. Shilpa Joshi, who is a dietitian, as well as a doctor, a diabetologist who is going to help us, giving us the tips on diet. Yes, what to eat, what not to eat for us, as well as for our relatives, as well as for our patients. Yes. She is the director of Mumbai Diet and Health Center. She's a practicing dietitian of a diabetic educator. She's a vice president 2019 and 2021 Indian Dietetic Association. She's an honorary secretary of All India Association of Advancing Research in Obesity. Nowadays, as you all know, we are more and more coming across our obese patients and young diabetics. Very difficult to deal with, very difficult to convince for them to work on themselves. And I'm very sure we need to have some association with somebody who can guide us rather so that we know it better, so that we can convey it for the better purpose to all our patients. She's also a master trainer in diabetes work conversation maps. She's a course director for National Diabetes Educator Program. She's been trained more than 3,000 diabetic educators. Yes, nowadays, patients we do come across who say that, yes, I have a trainer with me to help me out, or I have a diabetes educator with me. And I wish there are more and more of such patients who will come across such educators, and they are themselves been trained by somebody like very, very honorable Dr. Shilpa Joshi, who does it the perfect way, the way it should be. She has presented at various national and international meetings, including American Diabetes Association, International Diabetes Federation, and International Confederation of Dietitians. She has the runners-up recipient of, she's received a Webinar Wenham's International Essay Award in 2017 of the Academy of Nutrition and Diabetic Foundation on Malnutrition. She's been awarded a SRI Award by FOGSI in 2019. And yes, now we have such honorable, renowned person with us, a doctor with us to guide us on our diet so that we will be able to help others, including relatives and our patients, to help them out in the situations where it's high time that they really get themselves educated and work on themselves. Over to Dr. Shilpa Joshi. Thank you so much.
Thank you so much, Dr. Manjusha. Can you see my slides?
Yes, madam.
Yeah, and you can hear me, right? Okay, so good evening, everybody. And at the outset, I would like to thank all of you for inviting me here, most especially Dr. Shilpa Tivaskar for inviting me here. And I'm going to be speaking about a very interesting topic, that is diet for doctors. It is not something which is very different from diet for others. So it is specifically what diet should typically be consumed. Like Dr. Manjusha said that, we have a lot of metabolic disease happening across the spectrum of age and not just in older adults with the pandemic. So that is what I'm going to be speaking about. Okay, so this is just to begin the presentation. We are talking about positive health. And positive health, like you all know, I don't have to talk about this in details, but there is interaction of two things. It is about interaction of genetics, what you have, but also interaction, how you use that genetics. So typically it is said that as far as diseases are concerned, genetics loads the gun, but it's the environment that pulls the trigger. And what is the environment made up of? It is made up of what you consume and what you do with what is consumed, that is exercise. So we are talking about both interaction of genetics and food and exercise, all three of which are important for a positive health. Now, this is something which is very important, which I want you to dwell upon, that nutrition is an environmental factor that is of major importance. Now, there are many major changes have taken place in our diet over past 10,000 years since the beginning of agricultural revolution. But fortunately or unfortunately, our genes haven't changed that much. So spontaneous mutation rate for a nuclear DNA is estimated to be 0.5% per million years. Therefore, in past 10,000 years, our genes have changed by about 0.005%. But our diets have changed dramatically. So our genes today are very similar to genes of our ancestors 40,000 years ago. Genetically speaking, humans today are living in a nutritional environment that differs from that with which our genetic constitution was selected. So the foods that were commonly available in pre-agricultural times, that is lean meat, fish, green leafy vegetable, fruit, nut, berry and honey, were the foods that shaped modern human genetic nutritional requirement. Cereal staple grains, that is what we have come as part of our agricultural revolution, is the cereals or the grasses that we eat, are a very recent addition to human diet, and it actually represents a dramatic departure from the foods which we were genetically programmed and adapted to eat. Cereals did not become part of our food supply until very recently, that is 10,000 years ago, with the advent of agricultural revolution. Before agricultural revolution, 10,000 years ago, humans ate enormous variety of wild plants, whereas today only about 17% of plant species are actually providing 90% of the world's food supply. And this, my dear friends, is the actual problem. This is the problem, that we are not eating diverse for what our genetic makeup is. We are just eating very limited, just 17% of plant species, and that is why there are so many metabolic problems that we are facing. Okay, so we are indeed what we eat. Nutritional implication of high grain consumption upon human health are enormous. 99.9% of presence of planet, humans have rarely or rather never consumed cereal grains. It is only over last 10,000 years that humans are consuming cereals. When I mean cereals, I mean wheat, I mean rice, jawar, bajra, ragi, amaranth, so on and so forth. There is no evolutionary precedence in this, in our species, for grass seed consumption. We have had a little time, that is less than 500 generation since beginning of agricultural revolution, to adopt to a new food type, which now represents humanity's major source of both calories and protein. Rapid changes in our diet, particularly over last 100 years, are actually the potent promoters of chronic diseases such as atherosclerosis, essential hypertension, obesity, diabetes, and many cancers. So this was just a beginning which I wanted to give you, to tell you that we were meant to eat something very different, and what we are eating is something which is very different, and that is why we are having a huge burden. Now, this is the beginning, what I wanted to give you. From there, I am coming to what is more colloquial, what is more available nowadays. So first thing which I'm coming to you is, what is diet? So diet actually comes from a Middle English word called as diete, or a Latin word called as dieta, which means way of living. So actually, diet does not have much to do with food. It has to do more to do with the way you live. But when it is used as a noun or verb or adjective, it gets implication of food. If it is used as noun, then it is about a prescribed selection of food. When it is used as a verb, I am following a diet, means you're following a regime. Or if it is used as an adjective, that it is a diet chivda, that means it is having lower calories. So actually, if you look at the definition of diet, or if you're looking at the word origin of diet, it really doesn't have much to do with food. Now, what is a diet chart? Because that is what everybody is interested in, that we want a diet chart. So diet chart is a basic guideline of what you should eat and not eat. Wide range of disorders in the body can originate from making wrong food choices with respect to wrong food choices. Lifestyle disorders are prime example of what eating wrong type of food can do. In order to prevent such disorder, you can visit a dietitian who can design a diet chart for you. This will include the type of foods you should eat and in what quantities you should eat. So essentially, diet chart is a food prescription that is designed by a dietitian. Hello. Hello.
Varsha madam, can you mute the participants except Dr. Shilpa Joshi?
Yes, yes.
Please mute everyone except Dr. Shilpa Joshi.
Okay. So there are if you actually talk about diet charts and just go to Google and just type a number of calories. I've just typed 1500 because that's very common, but you can type anything and look at the amount of results that you get. 4,17,000 results only for a 1500 kilocalorie diet chart. So everybody has a Google. So actually everybody has a diet chart. So you really do not need my talk to understand what diet charts are there about. But if following diet charts would yield results, world would be really healthier. Everybody has Google, so everybody has diet charts. So diet charts which are there online are generic and they are not tailor-made, and hence they are rarely followed and they are rarely complied to. See, diet is as good as you follow it. For that matter, any therapy, whether it is pharmacological, whether any kind of therapy, it is as good as compliances. So diet charts which are generic are very, very difficult to follow. And most common question asked to a dietitian, even in a social gathering, is, or even on a Facebook chat, which I always see, is, "Ek diet chart de do, madam." So remember, the diet chart, there is nothing like a diet chart. That is the first thing which I wanted to tell you. For the best effective nutrition, an individualized medical nutrition therapy is necessary. So while there are millions of diet charts, the effective way to actually follow a diet is to follow medical nutrition therapy. Okay, so there are diets and there are also fat diets which are available. So healthy weight is not about diet, it is about lifestyle. A fat diet is any diet that promises weight loss quickly, and it is usually a temporary nutrition change. It is not about a lifestyle change. So for example, most common fat diet nowadays is a low carb diet, which everybody wants to follow. And then what happens is, people go on a low carb diet, they follow it for a few days, and then they say, nahi yaar, nahi ho raha hai, roti chawal thoda bahut to chahiye. They stop doing it and they start gaining the weight that they had lost. Now, what are the issues in doctor's life? And I don't have to tell you any of these. First is irregular meal patterns, resulting in issues like acidity, gas, bloat, irregular bowel movements. Weight gain issues during pandemic. There are stress-related issues which happened in pandemic because of overwork, finding comfort in food, or no work, and therefore finding comfort in food, and sedentariness, because otherwise life is so, I would say, mobile. Weight gain started happening when sedentariness set in. Then there will be metabolic issues like diabetes, hypertension, PCO in younger women. And then because of stress, lot of doctors and lot of people in general relied on comfort eating. I still remember when pandemic was in the first phase, the first wave, everybody on Facebook was busy baking cakes and taking photos and putting them on Facebook. So if so many people were actually baking, some of them were eating, and that actually resulted in weight gain. To say that, I want to first introduce to you what are Indian diets, because this is something that most of us are unaware. Most of the time when I counsel clients, most of them say, "Arey, hum to roti sabzi dal chawal khate hain." So we think if we eat roti sabzi, sab paap dhul gaye, and it is the healthiest thing on the planet. Now, this is Indian diets, and this is what the whole country is eating, whether it is North, West, East, South, or Central India. Typically, the diet that Indians are eating is 70% carbohydrate, around there, whether it is 66, 67, 65, but the mean average comes around 70%. And you know, when this study was done, before this, everybody thought that only South Indians eat a lot of carbs because they typically eat a lot of rice and they eat idli, dosa, and other things. But it was found that actually in Central India, people ate the most carbs. People were eating relatively lower in protein. 11 to 14% of protein was eaten. East was eating more protein because it is more non-vegetarian than rest of the country. And we were eating about 25% of fat in our diet, which is extremely skewed as compared to what are the diets which are recommended all across the globe. The most diet which is actually having lot of data and literature to be a good diet is a Mediterranean diet where carb percentage is only 50. So we are consuming about 20% more carbohydrate than it is recommended. So Indian diets are high carbohydrate, high fat diet. Now, if you actually look at effect of macronutrient intake on mortality, you will find that there is a lot of data to show that higher the carbohydrate consumption, and I think that slide got skipped or missed, higher the carbohydrate consumption, higher is all-cause mortality. So carbohydrate consumption has to be more. But there was another, so this is the date, this is the study which actually showed that higher the carbohydrate consumption, if you see energy from carbohydrate, if it is higher, the mortality is much higher as compared to any other nutrient, including saturated fat. So while all these years we were saying that saturated fat is the reason why cardiovascular disease happen, but you will see that as compared to even saturated fat, not that I'm promoting eating ghee, but the data shows even as compared to eating saturated fat, when energy intake from carbohydrate was more, there was the more mortality even from cardiovascular event and otherwise. So when you see, when you are replacing one nutrient for other, when carbohydrates get replaced by other nutrients, okay, mortality decreases, and therefore consuming lesser amount of carbohydrate. I'm not saying no carbohydrate. All I'm saying is consuming lesser amount of carbohydrate is important. Now, this is another very interesting data from a paper which was published in Lancet about 2 years ago by Dr. Sarah Siddleman. She actually did a meta-analysis of all studies which showed dietary carbohydrate intake and mortality among all kind of carbohydrate intakes. And what she showed was very, very interesting. She showed that while higher carbohydrate consumption leads to higher mortality, very low carbohydrate consumption also leads to higher mortality, and that there is a U-shaped relationship between carbohydrate intake and mortality, and lowest mortality is when individuals consume about 50% of calories coming from carbohydrates. So while low carbohydrate diets are not good, high carbohydrate diets are not good, what is actually required is somewhere around 50% of calories coming from carbohydrate, which is something which is actually important for consumption. Now, after this, I am coming to something which is very near and dear to everybody's heart, that is weight loss. So first of all, what is weight loss? So obesity-related conditions improve with a modest weight loss of 5 to 10%. In fact, there is a lot of data on reversal of diabetes or remission of diabetes, as it is called as, by a trial called as direct trial. And in direct trial also, it has been shown that about 15% or loss of initial body weight actually led to reversal of type 2 diabetes or remission of type 2 diabetes among many, many individuals. So Institute of Medicine defines as successful long-term weight loss as 5% reduction in initial body weight, which is maintained over 1 year. So my dear friends, weight loss is not difficult. 5% loss of body weight is very, very easy. What is the biggest challenge is to maintain it over at least 1 year. And the word at least has to be emphasized on. Maintaining the weight loss for 1 year or more than 1 year only constitutes as weight loss. And these are phases of obesity management or obesity treatment. The first phase, that is first 3 to 6 months, is the most beautiful phase, where The client is motivated, patient is motivated, doctor is motivated, dietitian is motivated, and the weight loss is beautiful. Weight comes down. And then there is a lifelong phase of this weight maintenance. And this is the most frustrating phase for the dietitian, for the doctor, for the patient. And when motivation is lost here, it will all come back the moment you stop doing what you were doing initially. So with this, I come to a few diets, that is ketogenic diet, because I'm sure all of you must be reading data on this. So what is ketogenic diet? It is a diet characterized by reduction of carbohydrate to 50 grams per day with a relative increase in protein and mostly by fat. So with fat, what happens is the carbohydrate burn down decreases, fat burn down increases to form ketone bodies in absence of carbohydrate, and formation of ketone body is 100% indicator that fat is being burned down, and that is why ketogenic diets are so very popular. Along with it, insulin levels also drop. Now, this ketogenic diet is very, very difficult to sort of follow. Therefore, we need something which is more simpler, and one of the most simplest thing that you can do in weight loss is follow something called as meal replacement therapy. So what is meal replacement? Meal replacement therapy is intended as a substitute for 1 or 2 regular solid meals or snack daily. So typically in a doctor's life, what happens is, which all of you lead, is that you go in the morning, probably eating a breakfast, and say you are stuck up in a OT through the day, and you really don't have time to come out and eat something, or you are not going to eat inside. And then what happens is when you come out, you are so starved, you are so famished that you are ready to eat whatever, anything and everything that comes in front of you. Now, more often than not, you will land up going to the canteen and you will land up eating a samosa, like Manjusha madam said in her introduction, or maybe a cup of tea, which is laden with sugar, or somebody who is more conscious may eat idli, or somebody who is conscious may eat a dosa, or maybe something else, a poha or a upma. Remember, all these are carb-laden foods. They just increase your hunger more because they lead to more and more secretion of insulin. So what happens is, at that time, if you use meal replacement, that is a drink, which is instead of solid regular food, drink it, finish your work, go back home and eat a proper meal, you are able to sustain for that time because you get good 200 to 250 calories, you get a lot of fiber, you get protein, and then once you reach home, you can eat something which is more standard or which is more better in quality and restricted in quantity. So the meal replacement is a term which is applied in scientific literature to encompass a wide range of food products, which include beverages, pre-packed, shelf-stable frozen entrees, meal and snack bars. But in our country, in India, we do not get any other formulations. We only get beverages. We get dry powders, which can be made into beverages. These foods can be used as sole source of energy for a meal or in combination with other food. It provides a nutritional balance of low-fat, low-energy meal. So these are meal replacements which are used. Then there are low-fat diets which were very popular when I was a student 25 years back. So low-fat diets contain between 11 to 19% of fat, and proponents of these diets actually say that calorie to calorie, fat has highest amount of calories. If you decrease their consumption, you will see that there is less energy intake and therefore there is more weight loss. Now, what are the metabolic effects of low-fat diets? Low-fat diets have shown to lower total cholesterol, specifically LDL cholesterol, and therefore lower the risk of heart disease. But the bigger problem in India is serum triglycerides. And with low-fat diets, serum triglycerides have been reported to increase. And therefore, low-fat diets become very, very hazardous. Blood pressure decreases in most of the subjects that consume low-fat diet. But low-fat diets can also lead to essential fatty acid deficiency. What are the Indian problems with low-fat diets? Low-fat diets are very similar to Sattvic diets, which are very essential part of Indian culture. But if you want to eat out, or you want to eat in a canteen, or you want to eat at your friend's place, there are no options for low-fat diets. Meal replacement is one of the options for low-fat diets. So, and what happens is dieters actually choose commercially prepared low-fat food like a meal replacement rather than choosing a fresh fruit, vegetable, nuts, which are recommended in diet. Now, the next part of diet, which I'm going to be talking about, is probably the most popular or in vogue kind of diet, which now is intermittent fasting. So intermittent fasting approach is a dietary pattern that is centered around periodic fasting. The two most common form of intermittent fasting are alternate day fasting or time restricted feeding. In fact, alternate day fasting is something that people don't do in our country. What they actually do is time restricted feeding, that is not eating for 16 hours and then eating in an 8-hour window period. Alternate day fast refers to minimal food intake alternating with a day of ad libitum eating. Time restricted feeding refers to restricting food consumption for a fixed interval of time, the most popular being 8-hour interval. So now what are the things of intermittent fasting? What are the data which is showing? So fasting feeding cycle should consider synchronizing with the circadian rhythm, since shift work is associated with higher incidence of obesity, diabetes, and cardiovascular disease. Time-restricted eating regimes with limited caloric consumption to midday were associated with increased weight loss and glucose control, while energy consumption in evening had negligible or worsening glucose control, blood pressure, and dyslipidemia. Therefore, there are few studies on intermittent fasting. There aren't many. But whatever studies are shown, they are showing that your intermittent fasting also should synchronize with the circadian rhythm. So it should not include eating at night. It should include eating more during the day, and there should be no eating in the later part of the day to get better results even with intermittent fasting. Now, you will also have a question that there are so many types of diets and which diet really works well. So there is a very nice paper by Designer Itar. It is an old paper which is published in 2006, where they have compared all kinds of diets. So there was a comparison of low carbohydrate diet, Weight Watchers diet, low fat diets. All diets were compared to each other, and it was a randomized trial. And they showed that percentage of people who completed 1 year of diet, the highest was when diets were normal to what they were consuming. So if you will see that Weight Watchers diet had the highest compliance, which is 65%. And the lowest compliance was for a high fat diet and a low fat diet, because it is not something that we normally eat. And what they showed was mean weight loss following all kinds of diet was only 2.1 kg. So it doesn't matter which type of diet you follow, as long as you follow that diet. So the amount of weight loss correlated with self-reported dietary adherence and not the type of diet. So this is something which is very, very important to remember. Then there are meal replacement programs. There are two types of programs. There are total meal replacement programs and there are partial meal replacement programs. And meal replacement programs actually caters to something which is very specific, to limit food choices. So every time you are in the hospital or you are eating out, the first question you ask is, oh, I am on a diet, I am watching my sugars, I am watching my weight, what do I eat now? And then you're confused because the choice is only dosa, vada, and samosa. So it limits the food choice. If you have meal replacement powder, just mix it, drink it, and you're ready to go. Ease of use, you don't need equipment, you don't need milk, you just need water. They're very good in taste and they're easily available all through. So there is a lot of data. These are forest plots showing meta-analysis of meal replacement versus food-based strategy. And most of the studies show that meal replacement strategies are easier to follow, easier to comply to, and give better results. Not saying that food-based strategies are not good, they are great. But for using food-based strategies, you need to be home, you need to be around healthy food. So if you are not home, say you are carrying dabba, and you are kind of a person who says, you know, I can't eat cold dabba, or you are carrying a dabba only with chapati bhaji and no protein, then you will see that your weight loss plans fail. And most of the times you wonder that, you know what, I eat only homemade chapati bhaji. When I go back home also, I eat homemade chapati bhaji, but my blood sugars are everywhere. My weight is not going down. That is because you are eating only grains. You are not eating a balanced meal plate. And a lot of times you find that using these kind of therapies, it is not a replacement for normal eating. But if you cannot eat normal food, then this becomes very, very good replacement. Now, with this, I'm going to decode some myths which are there surrounding most of the time foods. So the first myth, and Twisha is here, so I think Twisha will agree with me. A lot of times what happens is, this is a myth among everybody. I exercise, so now I can eat anything. So Twisha will also tell you about this, that exercise cannot be a replacement for diet. Exercise and diet go hand in hand. It is not that because you exercise, you can eat anything. And it is not that you are on a diet, so you don't need to exercise. So these are two complementary things. They are not replaceable. So if you see this one chips ka packet, to just handle that one chips ka packet, you need to walk 2.1 hours, okay, or 12 kilometers. Now tell me, after eating one packet of chips, nobody has the time and bandwidth to do all this, okay? After eating 2 samosas, which we were just talking about, we need to walk for 15 kilometers to burn it out. Even if you have the intent, who has the time to do all of this? If you're eating a pizza, you need to walk for 8 hours. So therefore, these kind of exercise things are not achievable if you are into recreational exercise. If you are a sports person, you can do all this. But if you are a doctor who has to go back to the hospital and give anesthesia to somebody, you can't possibly achieve this. So for the facts are 45 minutes of brisk walk, you burn approximately 250 to 300 calories. One plate of sev puri or a peg of vodka, empty calories, you gain about 400 to 450 calories. So this is startling. And therefore, it is said that a minute on your lips, it is lifetime on your hips. So before you eat, please think. It's a choice that you're making. It is exactly the choice that you make for other things, maybe your career, maybe your other things that you make. So think about eating, just don't take it for granted. Another myth which is there is dal should be avoided. And this myth is very, very rampant, even among medical professionals. So if we normally see a lot of patients of hyperuricemia, mildly elevated creatinine, which come and tell us, "Humko bola gaya hai, dal mat khao." So it is very, very important that dals should be eaten because they form a protein group in a carb-centric diet. Also, the carbohydrate in dals is of much superior quality than carbohydrate which comes from cereal. Cereal carbohydrate, if you have ever seen it on a CGM report, you will get a peak and a valley as far as blood sugars go. But if you are eating a dal-based carbohydrate, it is much flatter. So it is very, very important that you consume protein in every food that you eat. I want to reiterate this. Most of the time our breakfast is poha, upma, sabudana khichdi, paratha, bread butter, sandwich. We put vegetables in it. How much of us take care to put protein in it? You can't put protein in upma. What protein can you put? In poha, what protein can you put? Even the recipe doesn't permit adding protein. And therefore, a bowl of sprouts with it is very important. If you are not a big dal person, you are not a big sprout person, you can have some other kind like a paneer or maybe soya or soya milk or something else. But having protein is very important. This was a study which was done by me and my student, where we had shown that just consuming protein in every meal, we made khakra with protein, and we actually showed that when you use khakra, your blood sugars actually drop. So the myth is, if uric acids are high, dals should be completely avoided. And it is not at all true. In fact, there are other reasons why hyperuricemia happens, and this is a gout risk health pyramid, where it is shown that nuts and legumes, and here 1 to 3 servings should be eaten. What should be actually avoided for high uric acid and gout is white rice, white bread, potatoes, pasta, sweet, red meat, and butter. These are foods which need to be avoided in case person has gout, and not nuts and legumes, which are typically advised for people not to consume. So please let them consume dals because that will help them to decrease consumption of rice and bread. Bread means chapati. So if you have to decrease consumption of this has to increase. And if this has to increase, they have to consume dals and vegetables in liberal amount. Another thing that increases a risk of high uric acid is alcohol. So wine is neutral, but beer and liquor highly increase the risk of high uric acid. Another myth which exists is nuts should be avoided as they are high in fat. Of course, nuts are high in fat, but nuts are extremely beneficial because there is a whole data called as Predimate trials, which comes from Mediterranean countries like Italy and Greece, which has shown that nuts are extremely cardioprotective, and certain kinds of fat, especially in the vegetarian population, like omega-3 fats, the main source is nuts and seeds like walnuts or seeds like flax seeds or chia seeds. These kind of nuts and seeds, they are actually have antiarrhythmic properties, and nuts are capable of reducing LDL cholesterol because of the phytosterols present in them. So consuming nuts every day is very important. These are various kinds of nuts, and you will see most of them are rich in monounsaturated and polyunsaturated fats, which are very good for you. They are actually low in saturated fats, which are not great for you. So these are all bioactive compounds which are there in nuts, and they are very, very important for us. The next myth, which I think a lot of you will enjoy, is that there is a diabetes friendly oil. So this is a marketing gimmick. There is no oil which is friendly to anything. So remember, there are no diabetes friendly oils. So there are oils, so you know that saturated fat increases insulin resistance, decreases insulin sensitivity, increases triglycerides, LDL. So when you buy oil, if you buy in this realm, all oils are friendly for all problems. Now, what we recommend as dietitians is fats which are rich in MUFA and not in PUFA. The reason is PUFA-rich oils are very, very heat sensitive. And Indian cooking is very, very high on heating. So for people in this group who can cook, you know that the basic premise of Indian cooking is a tadka, where you heat oil to up to 150 to 180 degrees Celsius, put masalas in it, and then you cook food in it. At that point, if it's a polyunsaturated fat, the double bonds start breaking and the fat becomes trans fat. Monounsaturated fat, there is only one double bond to break. So the breakage of bond is much lesser, and therefore for Indian cooking, monounsaturated fats are great fats to cook in. Where are these fats coming from? From groundnut oil, rice bran oil, sesame oil, mustard oil, and of course olive oil. But olive oil is like 1,000 rupees a liter. So other oils are also as good as olive oil if you are going to use it for Indian cooking. So this is the effect of heating. So try not to overheat oil. Okay, even the nature of container use, whether you're using steel, iron, or Teflon, will not have effect on lipid peroxidation, but it will have effect on what goes into your stomach. So the frying is something which is really bad, and that is the food which is available most of the time in our canteen. So you will see there is a increased free radical generation and secondary product generation when foods are fried. And this is actually what leads to cardiovascular disease. This is what leads to oxidative stress. And this is also what leads to, increased risk of cancer, especially GI cancer. So therefore, frying is something which is not recommended. Now, this is another question a lot of you might have. What is the difference between a virgin oil and a refined oil? So of course, virgin oil is, by the name itself goes, it is untouched oil, where all the micronutrients which come with the oil, that is tocopherols, tocotrienols, and other things, which are antioxidants, are preserved. But now when you are using a refined virgin oil, okay, Virgin oils are great to use, by the way. But remember, when you're using virgin oil, please don't heat it. Please don't make tadka in it. Then should we buy refined oils to make tadka? No. There is something between virgin oil and refined oil that is called as double filtered oil or filtered oil. Those oils are good for giving a tadka. If at all you have to fry, I am not recommending frying, but if at all once in a while you have to fry, use refined oil. But if you're cold cooking, for example, you are using oil in a salad, you are using oil on chapati, you are using a little bit of oil on bread, then it's the virgin oil that you will use in such cases. Now, there are some practical tips. Eating rice is bad for you, a lot of you know, but you should add always a protein like a pulse, a dal, a curd, so that the glycemic index of rice drops. Instead of having a bowl of fruit, okay, which is moderate in glycemic index, add good quality fat. For example, almonds. You could also add walnuts. You could add pistachios. You could add anything of it. It becomes a low glycemic food. So anybody of you or your loved ones have diabetes, these are hacks that you can use to reduce the glycemic index of food. Again, moderate GI chapatis, you can make them low GI by adding vegetables to it. Methi, palak, kothmir, pudina. The list is endless. Amaranth. Just by adding fiber, it becomes low GI. Poha is an extremely high GI food, but when you add liberal amount of peanuts to it and you add a lot of lime to it, it drops the glycemic index and converts high into moderate. Definitely not low, but into moderate. Instead of banging on all these drinks, even the diet version, you can actually have a chas, you can have soy milk, you can have vegan protein, or you can have whey protein shakes, which are rampantly available in the market. Okay, this is how you should eat your plate. So this is called as plate partitioning method. Okay, so what is good way of eating? So you divide your plate into 4 parts. This is recommended by American Diabetes Association. Plates are only mine. Recommendation is there. So 1/4 plate should always be raw vegetables. A 4th plate should always be cooked vegetables. A 4th plate should be protein, and I have kept all protein sources here. So it can be sprouts, it can be paneer. Choose what you like. You don't have to eat all together, but the amount should be 1/4 of the plate. And only 1/4 of the plate should have cereal. Now, cereal can be chapati, cereal can be rice, but to your surprise, cereal can also be potato. So potato, my dear friends, is not a vegetable. Potato is a cereal. So you can choose any 3 of this cereal, only 1/4 of the plate. It also holds true for non-vegetarian food. So if somebody is eating non-veg, so if it's fish and fish curry and fried fish and rice, there should still be salad and there should still be sabzi to accompany this kind of meal, to call it as a balanced meal. So remember, there are a lot of foods which become favorite over the passing of time. One of them, which I had made at my house, because these are photos taken in my house, is Rajma Chawal. So a lot of people love Rajma Chawal or Kali Dal Chawal or something like that. But typically they find eating Rajma Chawal, they tend to eat a lot of rice. So this much of rice will never be enough. They will want to eat 4 times this. So ideally what you should do is limited carbs, that is rice, liberal protein, so rajma and curd, both 1 bowl, and a lot of salad. So this is again plate partitioning method. About half the plate is full of salad, or maybe a little less than half. A little less than half plate is full of protein, and just a less than half a plate is cereal, and that actually helps you to maintain your weight, helps you to maintain your blood sugar, maintain your lipids, more specifically triglycerides. Now, something this I'm sure all of you must be facing. Lot of times, people feel that idli is God's boon to mankind, because they feel idli mein tel nahi hai, it's steamed, to kitna bhi kha sakte. Now, typically what happens is when people come for their checkups to hospital, they do a fasting profile and then they go to canteen, they eat idli and then they do their postprandial. And when they do their postprandial, the postprandial are sky high. The reason is idli is a very high glycemic index food. And typically in a canteen, 3 to 4 idlis are given with a small bowl of sambar and a small helping of chutney. right? And people typically just dip their idlis in sambar. They don't eat sambar, and that increases their blood sugar and then increases their body weight. So if that has to be prevented, with one idli, you need to partition 2 bowls of sambar. Food is same. Nobody's going to cook separate food for anybody. But the amount of idli to sambar ratio, if it is changed, you will see that blood sugars are maintained much better as compared to just eating idli with a little bit of sambar. Now, there are papers on ordered eating. They are published by Osama Hamdi's group in Boston. But if you transfer that knowledge into Indian eating, this is an Indian plate where there is a dal, there is a salad, there is a sabzi, there is dahi, and there is roti. The order of the eating should be, you should always begin with protein. So you should first eat dal, then you should eat salad. Don't eat salad before you eat protein. First eat protein, then eat salad, then eat a little bit of vegetable, then eat your dahi. Now take more dal, more sabzi for your roti. You will realize you are not going to be eating one full roti. You will eat a little less, and lesser roti and rice you eat, better will be your health. At the same time, you are not going to be hungry. Some mid-meal options. People find that Mari biscuit is gift of God to mankind because they feel that koi calories nahi hai. 5 Mari biscuits with tea is eaten, it's 150 calories. Instead of that, eat one homemade paratha. That's also 150 calories, but 1,000 times better in nutrition. So this is methi thepla. Is pav vada and chai will give you about 550 calories. Jidhar pav vada milta hai, udhar hi aaju baju kahin moongfali wala hoga. So just have peanuts and chas, you will just get 150 calories. So you are saving on 300 calories. Like a Frankie with a Coke is 450 calories. A banana with soya milk is 200 calories. A bowl of sprout is just 150 calories. You need to know what to pick up, even as a snack in your home. So instead of eating a whole meal in a cafeteria, that is what I was trying to tell you, just choose a meal replacement shake. It will prevent a lot of overeating. Very busy slide, I know, but what I wanted to tell you here is nutritional diversity is very, very important. So when you are eating, see to it that you're eating different foods from different food groups. So when we typically ask our patients, and I can ask you also, do you eat green leafy vegetables? The answer is yes, hum palak methi khate hain. That's not eating green leafy vegetables. There are thousands available in the market. You need to eat all of them. So this is called eating diverse. This is eating non-diverse. Non-diverse eating leads to impaired health. Okay, so there are many, many green leafies which you can eat. And then there are fruits. Then can you not hear me? And then there are fruits. There are different fruits available.
We can hear you.
Yeah. No, I got your call. That is why I'm just ending it. Okay. So the change of attitude is I get a lot of clients who tell me, "Kya madam meetha khaya kyunki prasad tha." So prasadi meetha mat rakhiye. प्रसाद में ही फ्रूट रखिए ताकि मीठा खाना ना पड़े. So these are called as signal messages. This is masala dosa with chutney is a bad choice. Sada dosa with sambar is a yellow better choice, but lot of sambar with one sada dosa is the best choice. So in conclusion, diets have a huge impact on human health. Modification of dietary calories and macronutrients have been tried to decrease risk of metabolic disease. Lowering single macronutrient does cause weight loss, but its metabolic effects or benefits may vary. The biggest issue of any diet is compliance, and fad or extreme diets actually fail because they remove a nutrient or a food group. Mantra of a good diet is not only weight loss, but it is weight maintenance, and fad diets never succeed in that. So do not stop eating anything completely because that will not lead to sustained weight loss. It is prudent to have a diet which includes all food groups in recommended amounts, which will result in long-term benefits. Thank you so much for a patient hearing, and I apologize if I have taken extra time. Thank you so much.
No, sorry, that was by mistake, Shilpa. Yeah.
Oh, okay.
Yeah, Dr. Alpa Mehta.
Yes. Thank you, Shilpa, ma'am, for your information to us for regarding the basics of nutrients. Yes, we anesthesiologists are very irregular in food habits, but you told us very elaborately how what type of food we should take.
Now, can we go ahead with the chat box question, please? Yeah, someone asked, ma'am, that can roti rice be replaced with protein, fat, and salads?
Yes,
Dr.
it
Smita
should be.
Kulkarni, madam.
Yeah, so it should be ideally replaced. So we do not need to eat as many rotis and rice, and even if roti is jawar bajra, you don't need to eat as many. So if in one meal you can replace it completely, and in one meal you can have. So for example, if you're eating in hospital and you're carrying your dabba, you can just carry sprouts and bhaji and salad, or dal and bhaji and salad, and not carry a roti or rice. And when you come back home at night, you can eat a roti or you can eat a little bit of rice. That can be done, and it's really good. You change your nutrient composition completely.
Thank you. One more is there from Dr. Jyoti Bapat, ma'am. Is repeated small meals really helpful?
They are not at all helpful. They are really not helpful. Snacking leads to weight gain. So eat 3 meals and 1 snack, and that's okay. You can even eat 2 meals and 1 snack, and that's fine too.
Okay. And even I want to know which edible is more best for cooking for Indian meal.
Which oil?
Yes, edible oil. Which oil we should use for cooking?
So in Maharashtra, shengdana ka tel. You can use groundnut oil, you can use rice bran oil, til ka tel, mustard oil. You can use any of these. You can use olive oil. It's just very expensive.
But some says that groundnut oil is very thick and it is high in fat.
Ma'am, all fat, all oils per gram gives 9 calories. So it doesn't matter what fat you use.
Okay. And one more thing, just I want to know. See, we all are facing the problem of hair falling. So is there any food you recommend to decrease the
Ma'am,
hair?
hair is keratin, right? It's a protein. If your diet doesn't have protein, how will the hair grow? The problem is most of Indian houses cook protein only in dinner, dal. And वो भी पूरे फैमिली को अर्धा वाटी भी दाल नहीं बनाते, उसमें 5-6 जन खाना खाते हैं. The protein consumption in India is not there. People who eat 2 meals at home at least eat protein 2 times. Ideally, you should eat protein 3 to 4 times a day. So consume good amount of protein to have good hair and skin also.
Okay, got it. So we need to increase our protein intake.
Ma'am, the answer to this is every time you sit to eat, you have to ask yourself $1 million question. Where is protein? If there is no protein, you have no business eating food.
Okay. Yes. Now, one more in the chat box from Dr. Pankaj Gupta, sir.
Yes.
Is it a comments on Dixit diet?
So, sir, Dikshit diet, no. First of all, same diets don't work on everybody. So there are people in whom time-restricted feeding works. There are people in whom it doesn't work. But very important is when you follow time-restricted feeding, which is what Dr. Dikshit is promoting, what you eat once you start eating is very important. So आपने 16 घंटा कुछ नहीं खाया, उसके बाद 2 समोसा खाया, तो पूरा पानी में गया. After that, you have to eat 2 square meals, which are protein, fiber, and micronutrient rich.
One more myth, madam, that fruits are to be eaten at empty stomach. Is it like so? Because not. No. Oh, you
First
can have
of all, we don't need to eat many fruits. 1 or 2 fruits a day is enough. You know, I always give this example that the saying is, an apple a day keeps doctor away. The most important word here is one. If you have more than one, you have to go to doctor. I mean, you are all doctors, you have to go to each other. So the problem is that you have to consume 1 or 2 fruits, and they should be consumed between meals, not with meals. So they are snack. Basically, between 2 meals, when you get hungry, you should eat a fruit.
Okay. Now, which is preferred, sunflower oil or groundnut oil? The same question is asked by...
Sunflower oil is a polyunsaturated fat. If you're giving a vagar or a tadka or a fodni, then you can't use sunflower oil. Then you should use groundnut. If you're going to eat it cold, then you can use sunflower.
Okay. And if, could you told us about the meal replacement therapies, which we are not using, but now I think we should start using this meal.
You must use, because for doctors I have found it to be the most effective. OT के अंदर भी पी सकते हैं.
Okay. I think that's all from my side, and so many myths are covered by you. Thank you very much, ma'am. Is there any question from anyone? Shilpa ma'am, Shilpa Tivaskar ma'am?
Yeah. Shilpa Joshi madam, thank you very much for that elaborate talk. And the last part was, I was imagining, oh my God, I don't eat salad sometimes. And that hammering that there should be protein in each meal. I think I should hear your talk. I recorded talk every 10 days because it will, I know I'll follow it for 9 days. I'll forget it. Then I have to again hear it. Of course, I love samosas very much. And I think Dr. Kamdar sir has raised hand.
Can I ask one question?
Yes, sir.
Yes, sir.
Madam, I have been hearing a lot of things about the vegan diet. People say that I have turned to vegan.
Yes, sir.
And they said that after that, my blood sugar has gone down and my triglyceride has gone down. And then, can you comment something on that? Is it really true?
So vegan diet is a diet which excludes all animal products. So that also includes dairy. So you can't have even milk. Now the thing, and you can't have ghee and you can't have butter. So you can't have anything that comes from animal. The thing with vegan diet is, in its essence, vegan diet promotes eating vegetable and fruit. It really does not talk about eating so many cereals and pulses. So if you eat, your food choices are limited. You're not consuming dairy, you're not consuming animal food, you're not consuming half the kind of fats. So because your eating choices decrease, the weight loss happens, and therefore reversal of lot of metabolic diseases happen.
Now names, someone wants to know the names of replacement, meal replacement.
So they are, typically in our nutrition talks, we don't name because it is sort of favoring one company over the other. I have a whole list. I will send it to Shilpa Tivaskar madam, and she can probably send it to all of you.
Yeah, okay, thank you.
Over to you, Shilpa, Madam Shilpa Tivaskar, ma'am.
Yeah, there was a request by Dr. Venkat Giri sir, our national president. Sir will be back in 10-15 minutes. By the time, can we go on to next speaker, Dr. Twisha Parikh? Dr. Charushila madam, can you introduce Dr. Twisha Parikh?
Thank you so much.
Thank you, Shilpa madam.
Good evening, everybody. I'm
1 minute, Charushila madam. Varsha madam, please project the next CV. Varsha madam from Genica.
Yes, ma'am.
Please project the next CV of Dr. Twisha.
Okay.
Dr. Venkat Giri sir will be back in 10 minutes.
Yeah, I will be speaking next after the speaker.
Okay, sir is back. Sir is back. Yeah, sorry. Yeah, Dr. Varsha madam, can you project Dr. Venkat Giri's CV, sir? CV? Yeah, welcome again, sir. Dr. Venkat Giri, sir, our national ISA president and past secretary and GC member of ISA National, past president and secretary of ISA Kerala, past president and secretary of ISA Kasaragod, and professional well-being committee member of WFSA 2016 till 2024. Welcome, sir. Yeah, over to you, sir.
Madam, let the other speaker speak. I will speak next. I am in the theater now. That's why I told my slides are there. I will speak after the other speaker. One more speaker is there, no?
Yeah. Okay,
Let her finish her talk. I will talk next.
Okay. Actually, yeah. Okay. Sorry, sir. Yeah. Varsha madam. Varsha madam. Varsha madam.
Yes, ma'am.
Yeah. I'm so sorry again. Can I have Dr. Twisha's CV slide?
Yes, ma'am.
Dr. Charushila, madam, you can go ahead, please.
Good evening, everybody. First of all, I would like to thank the team BSA for giving me an opportunity to be here for this CME. I'm here to introduce Dr. Trisha Parikh. She is a consultant sports physician at Sir H.N. Reliance Foundation, Mumbai. After her, she has done her master's in exercise and medicine and a PhD from
Varsha, madam, you have to mute yourself.
complement her allopathic knowledge. She further trained to become an certified yoga instructor. She has authored many publications, as you can see written here, for which she has received so many awards. Also, close to my heart, she has been a doctor at Ladakh for La Ultra, which is run over a period of 5 days. The distance being 55, 111 to 22, 333, and 555 kilometers. She's here to tell us about exercise for doctors. Why is it important that we doctors need exercise? Now, there is, according to a study published in British Journal of Sports Medicine, doctors who are supposed to know the dangers of inactivity don't get enough exercise for various reasons. Almost 80% of doctors fall short in doing that. So let's understand from Dr. Trisha Parikh why, how, who, and when can do the exercises. For the doctors. Over to you, Dr. Trisha.
Good evening, everyone. Thank you to ISA for this invitation. Thank you, ma'am, for the introduction. So getting right into the topic, I think I'm always happy to follow after Dr. Shilpa Rishi, madam. It always gives me a lot of link to this whole thing around lifestyle, diet, and exercise. But now jumping on to this, and I would like to start off with as doctors, we always like to start off with, or we like to have case studies in our talks and discussions. So I thought of starting with something like a case study. So say as anesthetist, if you saw somebody with a tachycardia, sweating, shortness of breath, and a little bit of a flushed skin, what would happen? What would be your immediate reaction? Would you think this is normal? You would definitely think that there's some obviously physiological changes, but maybe slight pathological changes. What could be the probable diagnosis of something like this? I'm sure your mind is racing on various things, but in my particular example, our little minion darling is only doing some exercise when he realizes that, yes, his skin is flushing, heart is racing, and he's very short of breath. And that's why he calls it very dangerous. So that's what we're going to be discussing a little bit about. Is the fact is that exercise is a stress. Why is it a stress? Because there are two major exercise concerns, and that is one is of sudden collapse. The sudden collapse is most commonly something to do with cardiovascular reasons. It can also be other things like dehydration or maybe other things, but basically it's a sudden collapse. The symptom is a sudden collapse that we are seeing. The second is musculoskeletal complaints, which are less serious in nature, but they are probably larger in number. And what happens with them is that they actually limit people from exercising, because if you have some kind of complaint, ache, pain, injury, it puts you off exercise of some form for a period of time, which means that people's exercise goals get revamped, the exercise schedule gets revamped and things like that. So these are the major concerns with exercise. And why I wanted this little prelude is to answer the first question and to the main topic of our discussion today is getting started with exercise in your 50s and how to progress with it. So what do we want to do when we want to getting started with exercise? Common things that people want to do is there's some conference of or some local area which is organizing a 5-kilometer run, 10-kilometer run. So the question is, can I directly go in and do that 5K, 10K run? Alternatively, there is some gym which has started and is offering a free membership or a free trial session for a short period? So can I directly go in and do that 1 hour of gym session? Alternatively, a Zumba class, which is again being organized by someone. So can I directly jump in from not doing anything to a Zumba class? Or the simplest of everything, can I climb up a few floors? May not be 10, but even a few floors. But very often we get people who have, taken up this challenge that, I decided to start my weight loss journey or fitness journey. And so I decided to climb up 10 floors. And so the question is, can we start doing any physical activity just like that? Especially when we are around our 50s, because I thought most of this crowd would be around that time. And that's why I took up that thing. So the thing is that, is any screening required? So the answer to that is yes, a pre-participation health screening by a self-screening tool should be done for all individuals wishing to initiate an exercise program. A very simple form of this tool is something called the PARQ, which is Physical Activity Readiness Questionnaire. Simple questions, 7 questions which have to be answered in this, revolving around, do you have a heart disease, high blood pressure, pain in your chest while doing some activities, dizziness, have you ever lost consciousness, do you have any chronic medical condition, or are you taking any prescription medicines, or do you have any bone, joint or soft tissue? So just basic health related questions which get answered by this self questionnaire. And if you answer no to all of these, you can comfortably start off with exercise. However, if you answer yes to any of this, the questionnaire has 2 more pages that you fill in, and that again decides how do you proceed further. Now, what is the purpose of doing this kind of screening? Why would you do something like this? Like I said, there are some risks involved with doing exercise because a lot of physiological changes happen in the body. So to avoid these, we need to know who needs to get a clearance for doing exercise. And that's why we do this little questionnaire. Second, who would benefit from medically supervised exercise? Because that is now more and more promoted, being supervised while you're doing exercise so that you can be monitored for your parameters. And finally, who probably needs to avoid exercise temporarily because of some condition, could be musculoskeletal or medical. So identification of these type of participants is important. Now, to know as a very broad category, one, if you are a regular exerciser already, or if you are a non-exerciser, considering that we are basically talking about non-exercisers. Basically, if you are a regular exerciser, even if you have a known disease, but if you have been asymptomatic, you can happily continue with your light to moderate physical activity. PA stands for physical activity. However, if you have not been participating in regular exercise, but you do not have any cardiovascular, metabolic, renal disease, and no signs, symptoms which are suggestive of them, you don't really require a medical clearance. You just fill up that little questionnaire, understand for yourself or for your patients that no, these people are happy to go on with some exercise, provided again it's in the moderate to physical vigorous category. Of course, if somebody wants to do a high intensity type of activity, they might still want to get a little medical checkup, which is, which is now part of your various health checks. However, if you have known cardiovascular, metabolic, renal disease, and you are not regularly participating in exercise, you're still asymptomatic, but you do have some blood pressure, you do have probably a borderline sugar or something, it is still recommended to get a medical clearance. And of course, needless to say, if you are having proper diseases and are symptomatic, you obviously require a medical clearance. Now, what really do I mean by a medical clearance? It is something you basically need a physician assessment. That physician could be a family physician, it could be an internal physician, but somebody who has knowledge about exercise, who understands exercise, who understands the physiological changes with exercise. If it's going to be a simple walk, probably most people do understand, but if it is a particular type of exercise, which is, new form of activity, or some resistance exercise wherein you're going to push weights above your head level or something. So something like this, which is required, you want to get a proper physician assessment, somebody who understands medicine, somebody who understands the exercise aspects. Now, what will be included in this assessment will be totally dependent person to person. Will it only be a history and a detailed examination? Will it involve blood test? Will it involve a stress test, cardiac MRI, or what else? Is the sky is the limit then, but it has to be decided by the physician. In addition to this medical clearance, which is usually tailored around the the heart part of it and your metabolic conditions, orthopedic kind of examination looking at your joints is important, especially if you're having vague aches and pains, because chances of these pains increasing if you're doing unregulated exercise is very high. And like I mentioned, it is extremely common that people start off exercise, pain increases, and then they have a long break because then they have to discontinue exercise for some time. And so there is some kind of orthopedic examination which would be ideal. And lastly, a little other clearance, which is not really a clearance, but which is more of a testing, is actually doing a physical fitness test, which means, you do certain exercises to find out what is your baseline level, so that you know at what level can you start exercise. For example, if you get a clearance from your doctor and everything, and you are good to start off exercising, and you join, say, a boot camp. Now, in the boot camp, if they're going to get you to do push-ups, but the boot camp will say, okay, let's do 10 push-ups. But if you are not able to do a single push-up in a correct manner, then doing 10 push-ups is out of question, and then your boot camp becomes a waste. So finding out what is your baseline level is also important. So a medical clearance and a small kind of fitness test is ideal to start with. But again, like I said, that would depend on the physician. But the most important to answer this question on, can I start exercise suddenly, or or do I need to do anything before starting? You need to do some clearance, but the most important is the progress after that. It has to be a gradual progression. You should not jump onto anything very suddenly, because that's where the maximum amount of problems happen. So to take now a practical scenario, it's week 1, day 1, you have got your clearances, you've decided to go in and do exercise. Let's take Shilpa madam, who has just come back, who had decided 1st of March, she's going to kick on with her exercise program. 28th of February, night, about 12 o'clock, she gets a call, emergency. She is in the theater until something like 4:30 a.m. in the morning. But she has signed up for something on March 1st, and she's determined that she has to go and do the exercise. So what happens? She's signed up with a trainer, and that guy is like, yes, 7 o'clock, madam is going to be in the gym with her. She goes there to the gym, and he's like, yes, madam, aapka program bana diya maine, so let's start. So would you want to start off with that program right away? So the question is, every time before you start exercise, you want to ask yourself, how am I feeling? We call that, in our medical terms, the wellness score. In our exercise medicine terms, we call that the wellness score. In very simple terms, you basically want to ask yourself, how am I feeling today on a scale of 10? 10 being I'm all fresh, 1 being I am absolutely zero, or 1 being I'm absolutely dead. So chances are that, if you probably had 2 or 3 hours of sleep, you could still be fresh. I mean, I'm sure, anesthetists are used to that kind of lifestyle. You could still be fresh, but I'm sure you're probably not at your 10. So ask yourself this question and tailor the exercise. Make sure the exercise program is flexible to tailor according to the wellness score. Because if you are not feeling great and you start off, if there is fatigue, basically, that fatigue is mental, physical, cardiovascular, joints, muscles, you are not going to be able to perform your best. So make sure your program is tailor-made to that. The next thing you want is the correct exercise gear, which means typically the shoes, but yes, also the attire. Because especially if you're going to go running and things like that, because we have chafing and things like that which happen on the skin, especially in the Mumbai weather, if you're going to be outdoors. And finally, talking about the exercise session and how is it going to be. So let's jump to that. So what should be the components of an exercise training session? Now, irrespective of what is the duration of the session, every exercise session should have these components: a warm-up, the main part of the exercise, a cool down, and stretching. Now, the stretching could be part of the cool down, but essentially, yes, you want to do a cool down and stretching. So what the main session of the exercise would be involving aerobic activity, strength activity, flexibility, balance. Now, depending on how many times a week you're exercising, what are your exercise goals, this could vary a little bit. We will discuss that a little bit later. But let's first kickstart with warm up. So it seems Abraham Lincoln said this, that give me 6 hours to chop down a tree and I will spend the first 4 sharpening the axe. That's exactly what a warm up is meant to be, and are the advantages of a warm up. So it prepares the person mentally, physically, helps definitely in injury prevention. And if you're looking at a sporting kind of endeavor, if you're looking at a run or something, not just fitness, it also helps in performance enhancement. So the question is, what do I do for a warm up? I think if you typically go to Marine Drive or you go to a gym also, if you go to Marine Drive, see people, going for a jog run. If you go to a gym, you see people warming up. You will typically see them doing stretching, which is very common. This, that's the common type of things that people end up doing. Now, unfortunately, that's not the correct way to go about it. And when you want to do a warm up, this is the protocol that we follow. It is called the ramp protocol. What it means is the R stands for raise. So the warm up should be such that it raises your parameters, typically your heart rate. It raises your heart rate, slight amount of respiratory rate. You want the body to become ready for the exercise, and so you want a slight raise with this. So simple question, how do you raise your heart rate? Is by doing a simple jog. Jogging probably is the simplest thing that people adopt to do, and it will raise your heart rate. Is jogging alone enough as part of the warm up? Because that's typically what a lot of people do. No, that's where we have the second part, which is called activation. So what we mean in the activation, it is that what we want to do is key movement patterns are to be done, which are likely to be performed during the main exercise session. So if your main exercise session is basically doing a 7-kilometer run, then your activation could well be just doing a jog. But if you're likely to do something like a gym session, lunges, or something like that, then your activation steps should involve, say, something like a walking lunge. Even if you are going to do a running activity or jogging activity, a lunge is a broken up component of a jog or a run. So you could still do this because it specifically activates the muscles which are going to be involved during that activity in a very specific and, more importantly, controlled fashion. So when you go out and do the main exercise session, your muscles are kind of not in your control because you're at a higher speed and everything. So when you're warming up, you prime those muscles to get activated in a very controlled manner. So now they are prepared when they go out. It's like, we giving our final exams and we probably giving a prelim before that, or we giving a, unit test before that or something like that. And what you can see in this picture here is, say, somebody using an exercise band and he's doing kind of side to side movements with some resistance. So if your main exercise session is going to involve resistance activity in the gym, you want to use light resistance band to just do that kind of dynamic activity. The next part was the M, which is the mobilization, RAM, which is the mobilization part. Now, what do we mean by mobilization? I think all of us as doctors, and you all especially as anesthetists, are aware of the term mobilization. Ki patient ko mobilize karo. The patients the patients come out of anesthesia, this, that, and like patient mobilize hua ki. I'm sure everybody's heard this term often. Exactly the same context that we use it in exercise medicine, that you want to mobilize but here we want to do it for the joints per se. So if your today's activity is going to be upper body, you not just want to do the stretching, but you probably want to avoid the stretching, but you want to do specific mobility exercises for your shoulder so that you are loosening up the shoulder. What can also be done during this time is certain corrective exercises. For example, say if you had a semi kind of frozen shoulder, you had gone to a physiotherapist, they had taught you some rehabilitation exercises. This is the time when you want to do those kind of exercises. If they had taught you some stretching, but it has to be dynamic stretching. I'll come to that. So you want to do these kind of corrective exercises during this time of the mobilization. And lastly is obviously the potentiation, which is more related to performance enhancement. So I've not really covered it in detail in this talk. So that covered the warm-up. Next, coming to the main session of exercise. Like I said, it's aerobic exercise, strength, flexibility, balance, which form the components of an exercise session. Now, what I really mean by that is, just similar to an exercise, similar to a medicine prescription, we consider exercise also as medicine, and we give a prescription of all these components in the principle of what we call FITT, which is frequency, intensity, type, and time. Now, what I mean by that is every exercise which is picked, that is a type of exercise. So walking is a type, cycling is a type, resistance training is a type, Zumba is a type. Okay, so say take these examples of exercise. So that is the one of the T's. That is the type of exercise. Very similar to us giving a medicine, wherein a person's prescription could have an antibiotic, anti-diabetic, and a vitamin. So this running, Zumba all become the types of exercise. Now, in a medicine, just the way we would give the frequency of administration, here also we will give the frequency that you would want to do this exercise daily, you would want to do it alternate days, and so on. Then in the next component is the intensity. So just the way we have we have a dosage, like it is 50 milligram or 60,000 international units or whatever. In exercise also we have the dosage, which is how many sets is the person going to do, how many kgs weight is the person going to lift, or how many kilometers is the person going to run, or what speed is the person going to run at. Okay, all of that involves the intensity of exercise. And finally, it is the time, like the person has to take how often the medicine. Similarly, the exercise has to be done for 10 minutes, 30 minutes, 20 minutes, whatever. So this is really the basis of the main exercise session and how a FIT principle designs an exercise program. And depending on the exercise goals, each and the personality of the person, the state of the person, the medical state of the person, everything, this FIT principle will decide as to what kind of exercise prescription the person should get. So that is the main component of the exercise. Now, moving on to the very common things which get asked to us is, if the goal is weight reduction, what type of exercises should be picked? Okay. So the list here is aerobic exercises like walking, running, swimming, resistance exercise training, circuit training, kickboxing, HIIT, which is high intensity interval training, Zumba, Pilates, and the list is really endless. And I'm sure all of us are used to such conversations where we hear that somebody lost weight by doing a particular thing, whereas somebody else lost by doing some other form of exercise. And the question is how to decide which is the best kind of exercise. I will really follow on to what Shilpa Joshi ma'am mentioned in her talk, that the best form of exercise, the best form of food is the one that you follow. The best form of diet is the one that you follow. With weight reduction, it's exactly the same. It's the exercise which you can do the most consistently will be the exercise which will benefit you the most. There might be few differences of 20-30% between all exercises and the kind of benefits they give. I'm not refusing that each of these exercises give different benefits. But when it comes to weight reduction, the most important key is you need to do it consistently, and you need to do it. Gym memberships very often are maximum in the months of January and February. Not just the memberships, but the attendance is also maximum. And then as the year goes past, attendance reduces. Come Diwali, it's close to zero. New Year, it's obviously gone. And that's where all the plans fail. Like Shilpa madam mentioned, it's you want to have weight reductions qualified when it's over a period of a year. And that will happen only if you're consistent. And mind you, weight reduction doesn't just depend on exercises. It is exercise, diet, and behavior change. going back to this example that I was talking about, people saying that, oh, but, somebody just did Pilates and she definitely had, inch loss, this and that. When you go to any kind of group class or something like that, subconsciously, you kind of take the vibes also from the others. You meet 3 people there in the Pilates class, you speak to them, and you might pick up just one point that they are taking, from the exercise or a behavior change part or a lifestyle change part. You might pick up something from them and you also incorporate that part. Additionally, when you do kind of group exercises, depends on the person's personality, but when somebody does group exercises, there is a huge social element involved. As we get older, we want that particular social element slightly. That's what we've observed, and most studies have also shown. And that's when your adherence to exercise improves. So like I said, the most important part here is adherence to exercise. So when the adherence improves, then automatically you are going to see a weight reduction. The other important thing which comes in with weight reduction is and consistency and adherence is there being some motivation and a long-term motivation. The motivation is not just ki meri beti ki shadi 3 mahine mein hai. Unfortunately, that's not the only motivation. It has to be a more long-term motivation. So really with weight reduction, it's all these factors which go in, and that determines the consistency of the exercise. The 2 things that really determine, in addition to all of this, that what is going to ensure the consistency is your enjoyment level, and it is going to be how many barriers do you have to do this exercise. So for example, swimming is a great exercise, but if you have to go get into the car, drive about 8 to 9 kilometers to get to the swimming pool, that becomes the barrier. If you enjoy that drive, if something else is happening along with the drive and you say, no, I can definitely make it to the swimming pool 4 days a week without fail, then it's great. But if it's going to be like, no, I have to take an auto to go to the club, this, that, and there's going to be barriers. No, please, swimming might be a greater exercise, but pick a simple thing like walking in your garden or your building or just in your locality, because that might still be good enough, because you will be able to do it more consistently. So wanted to touch up on that with weight exercises for weight loss. Then coming to the aspect of exercise intensities. Okay, so I think again Shilpa ma'am mentioned about the amount of exercise you need to do to burn a particular amount of calories and those kind of things. So all of that is important again for weight loss, because weight loss will be determined by at what intensity you're doing an exercise for how much duration. So to briefly tell you on what are the high intensity exercises, what are the low intensity exercises. Intensity in exercise is classified by a term called MET, which is metabolic equivalent. I'm sure some of the anesthetists are also slightly aware of it. And it is, 1 MET is basically your resting basal metabolic rate. And all the intensities are calculated as multiples of METs classically. There are other forms also to calculate intensity of exercise, but this is a simple way to classify because a wide range of activities can be classified. So standing and performing light work like bedding, cooking is something like 2.5 METs. Heavy cleaning, sweeping floors, 3.5. Recreational badminton, doubles tennis is 4.5. Mind you, you jump onto singles tennis, it becomes 8 METs. Jogging at 10K per hour is 10 METs. Performing Zumba at an average of 79-80% heart rate max is something which is going to burn 369 in a 45-minute session. Okay. So heart rate max is another way of obviously classifying exercise, percentage heart rate max. And these are the rough ideas of what is the intensities of exercise. If there is a particular activity you're doing, you want to know the intensity of exercise. Very often it's easy to find it on the internet. Most of the values are fairly, you cannot bang on these values, but most of the values available are within the 1 or 2 MET range. So you can if you just basically want to compare whether is this a higher activity or this, it's good for that, comparing the METs. So maximum calories burnt, like I said, will be dependent on the intensity and duration of activity. The intensity of activities are classified as percent heart rate, percent VO2 and METs, but it is also dependent a lot on the body weight itself. And that's why we hear this classic thing that, initially I could lose a lot of weight, but then I have plateaued. Okay, so that very often that also happens, that if you are doing the same amount of exercise, but typically what we see is that people can increase their intensity, but if you are doing the same intensity of exercise, You might lose more weight in the beginning because it's dependent on body weight, the amount of calories you lose, and then it kind of reduces. Now coming to after we finish the main exercise session, then like I said, there should be a cool down, and stretching could be a part of the cool down. So in the cool down, you typically want the parameters which have all risen during exercise, all the muscles which have been completely warmed up and everything. You want all of this to typically come down to a basal level. In crude words, what we call the lactic acid accumulation and basically all the metabolites which have got stemmed up in the muscles during all of this, during a cool down and a stretching is the period where you want the circulation to be continuing so that all of these can be gradually washed out of the system. So that's why you want a cool down and not just a stretching. So the cool down is basically at a much lower intensity. You're just doing a simple walking, simple dynamic stretches again, or something like that. So I've been using the term dynamic stretches often. So I'll just show you what do we mean by dynamic stretches. So typically stretching has dynamic and static two types. Dynamic is when somebody is doing movement. Okay, so you're stretching, but there is movement happening. Whereas static stretching is when you typically hold a particular muscle in a static position. They are both useful in their own respects. So dynamic stretching has been shown to improve flexibility, increase power output, and increase neuromuscular activation, and can also in fact increase performance, and hence it is best performed before training. The RAMP, the activation and the mobilization part that I spoke about. Whereas static stretching is improving the range of motion, flexibility, but it helps more with the muscle recovery. And in fact, it can be detrimental to performance, and hence it is best done after a training. And in fact, it has been shown that if stretching is done before exercise, it does not, static stretching, it does not really reduce the risk of local muscle injury or muscle damage. And hence, the static stretching is typically to be done after an exercise. Now, what are the various types of static stretching? Obviously, this is the commonest one that people use for the upper body. What you can see in the photograph here, other photograph is something that people use for the lower body. This is for the front muscle, which is the quadriceps. Lady in the picture is doing another one for the triceps. You would want to statically stretch those muscles which you have exercised during the exercise session. So if you have played football, you have probably used a lot of your thigh muscles. You want to do stretching of each of those muscles, including your adductors, your abductors, your hamstrings. Everything needs to be stretched, and they could be stretched statically. Now just touching up on long distance marathons, because they are obviously in vogue thing for the last decade. A full marathon is 42, half 21. Those of you in the audience who are avid runners, obviously I don't need to tell this to you, but those who are probably just starting off, my advice is more for them. It's very common to have these 5K, 3K runs as part of, smaller as part of bigger events which are happening. They'll just have these things, and you could be encouraged by a friend to take up something like this, or a colleague to take up something like this. Like I said, now we have conferences. Pre-COVID, we used to have conferences where that had just started, where they would organize these runs, and say on the day 2 or the day 3 of the conference morning, people are doing a run, which is an absolutely brilliant thing to do. But my only worry with these things is, if you're an avid runner and everything is great, if you have some capacity, it's fine. But otherwise, just be careful while doing these kind of runs, cardiovascularly as well as from the injury point of view. And if you want to go ahead and do any of these challenges, just follow the basic rule of doing a warm-up, doing the exercise session, a cool down, and a stretching. And that should take care of a lot of things in quite a good way. Even if your exercise session is going to be 20 minutes, sorry, even if your exercise session is going to be just about 20 minutes, still try and do a warm-up. Ideally, a warm-up should be at least 10-12 minutes in itself. But for some reason, if you have just time of 20 minutes to do exercise, don't just directly jump on, do a little boot camp activity and come out. No, please do a warm-up, do your exercise session, and do a cool down. Your cool down could be a stretch. You need not, do a jogging kind of cool down. It could be just a stretch, but at least follow these components to ensure safety of heart as well as muscles. Because basically, I think I'm stressing a lot on these because as an exercise and sports medicine physician, basically majority of the people come to me first with an injury. And when we take the history of injury, it's typically when they've done something too fast, too soon. Climbing up 10 floors is so common. Joining some kind of HIIT kind of class is so common. Weight loss for marriages, super common. Then you have a target that wedding is in 2 months. In 2 months, I have to lose this kind of weight, or I even want to become fit. Very often, it's not just weight loss. Young girls taking up, high intensity classes because they just want to tone themselves then injuring themselves and everything getting messed up. So that's the reason I'm stressing so much on the injury part. Coming towards the end of my talk, wanted to touch up on online exercise sessions because again, they have been the in thing in the last 2 years. Everybody, including me, we've done online consultations, we've done online exercise sessions, rehab sessions, everything. We have gotten better over it. We were not doing so much of all of this before. A few things that you want to consider: does your house have enough space, and is it safe to do the exercise session in your house? Do you have the right gear and equipment? You will obviously most probably have the right gear in the form of clothes. But if it is equipment, do you have the correct equipment? Very often the equipment could be just a bottle of water. Instead of dumbbells, we've been advising people to just use, say, half-liter bottles, 1-liter bottles, something like that. All of these, dumbbells are very ergonomically shaped that you can hold them in the center. Your 1-liter bottle, if it's going to be a Coke bottle, plastic bottle, which has a center, which is, a huge belly, they are not the most ideal to hold on to. So, even if you're doing such things, please make sure you're having the correct equipment, because if that bottle is going to fall on your foot, you're already probably suffering in your 50s, you're having some kind of osteopenia. That bottle falling on your foot is not uncommon to lead to a small phalanx or a metatarsal fracture. So please be mindful of that. Finally, the most important thing with an online exercise session is, what is your exercise literacy? Have you exercised before? Do you understand the terms that the teacher might use during the exercise session? Will you understand where to stop if there's some problem happening, because the teacher may not be able to fully have a full view of you? Those are the important things when it comes to your own exercise literacy and the safety of the exercise. And finally, the teacher's experience, of course. So like I said that, if the teacher should know, even on that small little Zoom window, what she's supposed to look for when she's getting the person to do a particular exercise, as to where the person commonly goes wrong, and she's able to give that cues to you. So that was it from my side. I've tried to cover the common aspects that we get asked, and I think the most importantly is whether we can go on and exercise just like that. So that's.
Yeah,
Thank you, Dr. Pisha. You touched upon almost all the topics.
Can we take the questions later, please? And can we invite our national president, Dr. Venkat Giri sir?
There's only one question.
Okay. Yeah, you can finish off that.
Yeah, she can answer. Let her answer and finish that. No.
Okay, thank you so much, sir. Dr. Charu madam? Charu madam?
Yeah.
Yeah, you can go ahead, please. Yeah.
Be done by using different yoga. To do a cool down by using different yoga poses.
Yeah, so provided those yoga poses are not raising your heart rate too much, and they are the typical static kind of stretching yoga poses, yes, they can be done for sure. So a yoga pose could also be like a Parvatasana, wherein you're not really stretching, but you're actually doing an exercise standing on your toes, and also may not be something like that, but another asana when you're going down and touching your toes, which is helping you stretch your hamstrings, probably yes, that can be done for sure. And it also helps with the breathing.
One more question I have for you, Dr. Pisha. How frequently do you advise CT angiography?
Ma'am, totally depends on we don't even advise it for everyone right away.
Okay.
So we don't even advise it for everyone right away. It is totally dependent on the person's risk factors And earlier the guidelines were that, we would, the evaluation guideline involved ticking off a particular number of risk factors. So if the person had 2 risk factors, they had to do this. If they had 3 risk factors, they had to do this. But now it has been left to the discretion of the evaluating physician. Basically, if you are wanting to go in for high intensity exercise and you're having some risk factors, or even if you're not having risk factors, but you have age and you're wanting to go in for high intensity exercises, you get yourself medically evaluated, and then the physician decides as to what is the CT, what is the type of investigations required. But having said that, I myself regularly assess people who are even in their 50s and 60s, but we do not get their CT angio done. We would just do basic exercise test. So it really, and we would also have people in their 50s or 45s. In fact, a 45-year-old gentleman whom I've seen, whom I have done a full everything, CT, angio and everything, because the risk profile was such and the activity demand was such.
Okay. Thank you, Dr. Krishna. Just a takeaway message from this topic is you can start your exercise at any age, but after health screening done, start gradually, do a warm-up, seek a coach, and motivate yourself, keep motivating your family, your friends, and check the barriers, keep them to the minimum. Thank you so much, Dr. Tumisha, for being here. I think Shilpa Divaskar, please take over.
Yeah. Thank you so much, Charashila madam. Dr. Varsha madam, can we have screen sharing by Dr. Venkatgiri sir? First, can we have CV of Dr. Venkatgiri sir, and then screen sharing by sir?
Yes, ma'am. Shilpa ma'am, can you stop the sharing? Shilpa Tiwari ma'am. Sorry.
Is this my sharing?
No,
No, that is sir.
Ma'am, this is you, I think.
No, must be Dr. Venkatgiri sir.
It's my.
Yeah, sir is sharing. Varsha madam, sir is already sharing the screen.
Okay.
Yeah, welcome sir. Sorry to keep you waiting. And we are very happy and lucky to have you today. Yeah, we are looking forward for our new drug. You want to...
Is it okay that this thing, the slide show?
No, we are not able to see your slideshow. We are just seeing your...
It's showing slideshow here.
Varsha madam, can you help Dr. Venkatgiri sir?
I will once again see that.
Varsha madam? Sir, yeah, you have to double click and open
yes,
the
ma'am.
slide. Yeah,
it is open.
Double click, sir.
I have opened it. Slides. I have put to slideshow also. I don't know why it is not coming. Let me check.
Sir, please stop sharing.
Yeah,
then open slide.
Yeah, I will do that once. Stop video. Yeah. Stop sharing. It is showing your screen is sharing. Your screen sharing.
Stop that, sir. Stop that.
Okay.
Yes, please open.
Okay, screen share.
Yes.
Both are view to speaker view.
Now first open your slideshow and keep, sir.
Okay, it is open. It is open. Slide is open.
And now you can share the screen. Is it okay, no, Varsha madam? It's that.
Yes.
Once again, I will open my PPT and keep it ready.
Yeah, open and keep the first slide.
I will minimize and keep that. Okay, that's ready.
Okay.
Sir, please start share screen.
Share screen. Yes. Okay, is it coming now?
Yes, sir.
Yes, sir.
Can you make it full screen? Slideshow?
Yeah, slideshow. I made a slideshow.
We are seeing it in a smaller version. Can you make it full screen?
Yeah.
The box, Varsha madam, guide kara na.
Oh, yes, ma'am. Sir,
Yeah.
sir, please click slideshow.
Sir, slideshow at the top or maybe at the bottom where you see the small square.
The third icon on the bottom, sir. The third icon on the bottom.
Okay.
Third icon.
Third icon on the bottom, sir. Just click that. It will become full screen.
Near that 65% which is written at the bottom.
Yes, yes.
No, that is new share. It's again coming new share.
We can see your slideshow, but it is just not full screen. Where that 65% is written, yeah, left to that, yeah.
Something else is coming in that.
Varsha madam, if sir clicks the top line also, it is okay?
Yes, 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 ma'am.
I will exit and rejoin, then that will be easy. Let me speak.
No, this is
yes,
also
sir, that's the best
okay,
thing.
sir.
Yeah. That's the thing is that I will log out and log in again, then it will be easy.
Okay. So most of us have started using Ropivacaine heavy. But there is always an apprehension. Whenever there is a high risk case, and then I am apprehensive whether I should still go with Ropivacaine or if suppose the action is not definite, I should go with Bupivacaine heavy. Dr. Sandeep Mutha, sir, you have any view on this?
Hello. Yeah, means initially when you're using Ropivacaine, it's better to do with regular cases. Once you get used to it, so I have done today only 25% ejection fraction for fracture neck femur. Then I used Ropivacaine because I have used almost 25 now. So I used Ropivacaine 1.5 cc, and it had a very good effect. So you can start using it once you get used to it. Don't use it initially. Initially, use it in normal, simple patients.
Yeah.
But what was the duration of surgery?
The duration of surgery was 1 hour 25 minutes. And the analgesia lasted, I had given in the morning. The analgesia lasted just now. Just now, the first dose of paracetamol is given to the patient.
Okay.
Dr. Venkatgiri, sir, yeah. We are seeing it as a
slideshow.
So at the top, if you, at the top, yes.
Then click from beginning, first option.
Go to the leftmost option from beginning. No, not home, below that, yeah, from beginning.
From the beginning, yeah.
Yeah.
Okay, right. Thank you. Okay, is it audible?
Yeah, it's audible.
Okay. Good evening. Sorry for the delay and all. And thank you for inviting me and asking me to share my experience or opinion on this new drug, Ropivacaine heavy. Some things are from the literature and other things are for my own experience the last 2-3 months using this Ropivacaine. As you know that a few brief description on the local anesthetics. As you know, there are two types chemical esteramide. Now we use more of amide and ester is not used at present. And these are chiral compounds which are racemic. That means they have exist both in levo and dextro form. And most local anesthetics are amide are either in levo or reso form and dextro or levo, and usually in the equal proportion. To
Sir,
go to
your
the
slide
history,
is not moving.
it's not moving.
No, sir.
Slide is not moving.
But I see no slides. Okay.
We can see the first slide.
Yeah.
You can again try the
Now?
slide, clicking
Now?
slideshow.
Now?
No, can you try again going to the slideshow?
Okay.
Going to the top near home, insert design animations and slideshow.
That is not coming in the screen now.
Okay.
Sir, एक बार stop कीजिए screen and again share.
Stop share. Okay.
हाँ अभी share कीजिए.
Okay. Okay.
अभी slide show पे click
Slide show?
कीजिए. हाँ yes. No. Yes.
After that, yeah. There.
Click.
From the beginning.
Yes, from beginning.
Okay. Why the slides are not moving?
No,
Is it
sir.
moving?
Sir
Not
has to
moving.
click the first slide, Varsha madam.
Yeah.
Yes.
First slide वर double click करावं लागेल का?
नहीं ma'am.
No, this is the first. Is it coming? See, I see moving on the second slide. It's the second. No.
No, we can see the first slide and we can see the slideshow on the left side.
No, now yeah, it is moving in my screen. Let me check that way.
Varsha madam help करा काय
Is
करायचं?
it moving now?
Okay, okay.
Not moving?
No, sir.
सर प्लीज पर फिर से साइड स्लो पे क्लिक कीजिए ना स्लाइड शो पे.
Where that 98% is seen below on your screen. Can you see that, sir?
No, I can't see. Let me read again. Yeah. Okay. I will exit full screen and go to the.
Suppose you click to the second slide. You go and click. Yeah, if you can.
Is it second slide?
Yeah. Now we can see the second slide. Maybe we can go that way.
Okay. We will go that way. Right. Okay.
You can click each slide individually.
I will click individually each slide. Okay. So yes, we will go to the second slide. As you know that the classification ester or amide, and now we use more of amide. Ester is currently not used, and this amino amide local anesthetic belong to the family of pipecocelidins, and which are chiral compounds that are asymmetric carbonyl, which are either in S or L form, levo or dextro form. These compounds were synthesized in 1957, and there were 3 amide compounds synthesized: mepivocaine, bupivacaine, and ropivacaine. But of 3, only bupivacaine was used for clinical use, and among these, ropivacaine has a pure S enantiomer and was not used for clinical practice, but was used only for research purposes. In the chemical structure, ropivacaine is almost similar to bupivacaine, but it has a propyl group in the piperidine nitrogen atom compared to bupivacaine, which has a butyl group. And it has a short carbon chain, and that makes all the difference in these drugs. So this ropivacaine is less toxic compared to bupivacaine because the cardiac sodium channels favor localness in R form, that is dextro form, whereas ropivacaine is in levo form or S form compared to others. It does not have to both R and S, it has got only S. And it has a short carbon chain, so it is less lipid soluble and it doesn't penetrate more into the nerve fibers. Due to these 2 factors, that is one, because of this S form and less penetration, ropivacaine is less cardiotoxic and CNS toxic than bupivacaine because it does not cross, it is less lipid soluble and So it crosses the blood-brain barrier less and also does not bind and go to the cardiac. To go to the history, this bupivacaine was or etidocaine were causing cardiac arrest, and they were recognized in 79 by Albright, where he reported 6 cases of accidental intravascular injection because they were used to give for brachial block or intravenous anesthesia, and the patient had arrest and died immediately. And in UK also there are 5 cases where they give regional anesthesia and performed by the trainee casualty MOs and these patients. So that was the time when it was reported that bupivacaine causes sudden cardiac arrest and death. And they thought, and it was due to faulty tourniquet because the drug was injected putting the tourniquet, but once the tourniquet was not altered, the drug went to the circulation immediately and caused immediate death of the patient. But in that time, again, the reassessment or reevaluation of the ropivacaine started, and it came to clinical practice in 1996. So it was commercially available for clinical use outside India from 1996, but in India it came only in 2009. But it was only a isobaric injection, not a hyperbaric or heavy injection. So the drug distribution was not very happy, and there was more capillaries spread, and use of plain bupivacaine and ropivacaine for spinal was very limited. It was only experimental, though they were telling that you add dextrose and give, we are not giving the exact drug, so it was not used in that. So hyperbaricity with glucose, the difference is glucose-free ropivacaine is marginally not only isobaric, it is hypobaric. It causes unpredictable spread in the CSF and results in inadequate distribution of block, and the gravity also does not encourage their spread. So hyperbaric solution, they are more predictable with greater spread in the direction, and gravity is less interpatient variability. Motivated by this, ropivacaine heavy was used for clinical practice. So essentially, the hyperropivacaine, it has already caused the third phase of multicenter trial, but efficacy-wise, ropivacaine was tried with both the 0.5 and the 7.5, but the 5 was not effective compared to 0.75. When we compare both ropivacaine and bupivacaine, ropivacaine is little slow in its action and little shorter duration of the period, and takes more time to get a higher level of sensory block, and the onset of motor block is also delayed compared to bupivacaine. And regression of the block also, it is faster than ropivacaine. So in conclusion, the efficacy parameters are both comparatively equal, but it is less with the bupivacaine. And regarding the adverse effects, they are mild in nature when it is used in 0.75%, but does not have the effect on cardiac or neuro effect, because it is less lipid soluble and does not penetrate into the tissues. Because of less lipid solubility, one problem is that it does not cross the myelinated fibers easily, and motor blockade is comparatively less compared to sensory. Sensory block is good, but it has got less motor blockade. But in my experience, I did not feel that difficulty in getting the motor blockade. So adverse effects. See, adverse effect compared to bupivacaine, it is less. Overall, it is only 0.8% when compared to bupivacaine, which had 13%. Tachycardia is less. Bradycardia also less compared to bupivacaine. And in general, pyrexia and hypotension are less. And in the limited dose which I use, I find a little less hypotension, But after a long time, maybe after 1 hour or so, we see some follow BP, but not immediate follow BP with the ropivacaine. But it definitely takes more time to act than bupivacaine. The contraindications are hypersensitivity, ropivacaine, or other local anesthetics, and general contraindication related to spinal anesthesia. And precautions that hypersensitivity, ropivacaine, cardiovascular diseases, hypovolemia, hepatic and renal impairment, acute porphyria, and poor general health. That is general like any other drugs. And adverse reactions are nausea, vomiting, urinary retention, bradycardia, temperature elevation, allergy. These are more of theoretical. I feel that I did not see any of these in my practice. But in my personal experience, I used it for cesarean sections, general surgery like hernia, hydrocele, appendicectomies, gynec surgery like hysterectomies, orthopedic both open reductions and implant removals. Used children and adult children also. I used for hernia surgeries and with my observation, this causes less hypotension. But there were few cases where it causes good hypertension, where gave little higher dose, it caused more of hypertension. Otherwise, generally, our observation is that it causes less hypotension than bupivacaine. Today also, I used for 4 cases and did not have hypertension. That 120, 130 systolic came only up to 98. That's after about 45 minutes. Till that time, it was slowly coming down, not like others. Other observations, action is delayed. Many times we were thinking that it's not acting, whether we should change or give once more. That was many times. It takes bupivacaine, okay, 3 minutes, you get the action. This ropivacaine sometimes took almost 10 minutes when we were getting ready to give second spinal or changing technique to GA. It was active. That was that we have to wait for some time. Maybe because of that, we are checking more motor block than sensory, because motor blocks, it takes more time because it has to penetrate into the nerve. It takes more time. Another interesting finding was not acting, that I do not know how much it is. When the CSF was blood stain, it did not act at all. Even 2 attempts we did not act. But whereas it was the same drug, whereas when we gave bupivacaine, it acted. Same drug, what I did was I used one ampoule, gave one cesarean, another cesarean. One was a blood stain, another one clean. It acted in one, it did not act in the other one. But second, we thought that we will give bupivacaine, it acted. So that's my observation. I do not know whether, because we get to do that, we should get more blood stained CSF, then only we can say that. At least 3 or 4 cases we had where it did not act at all. We had to change the drug or technique, because when 2 times given it did not act, we had to give GA also. That was that. And additives, I have added both fentanyl and dextromid as additive. And dextromid, when it had a very good action up to 7 to 8 hours of analgesia. And our staff was very happy that the patient did not have any complaints post-operative, especially for hysterectomies, because after 2-3 hours they start telling pain and all. They had no complaints for about 7 to 8 hours when dextromid was added. Fentanyl we added, that also we tried around 3.5 hours. Surgical time we could do even orthopedic up to 3.5 to 4 hours with the fentanyl. Post-op analgesia we had up to 3.5 hours with fentanyl and 7 to 8 hours with dextromid. Thank you. This is my experience. With others who have used can tell that. We can have a discussion how it acted.
Thank you so much. Yeah, Dr. Tendulkar sir, please take over.
Good evening, sir. This is Ganesh here from Mumbai.
Please.
Sir, I would like your opinion on the doses of dextromid when it is, the doses of ropivacaine heavy when it is used for longer duration of surgery.
Ropivacaine, drug quantity was equal. When longer time with the dextromid only, I used dextromid for long action. Not tropiocane, I used up to 3.5 cc for hysterectomy, and depending on the patient's height and weight. But that did not cause much difference. Only addition of the, because
Yes, sir.
actually it has lesser, even they also say it has a lesser duration of action compared to this thing, because even there were 0.7%, even the study also is short duration of action than bupivacaine. But with the dextromid, definitely it is alone. Advantage only they think in cardiac safety. Otherwise, we are happy with the bupivacaine. They say that cardiac safety is the advantage by accidental injection. Otherwise, with bupivacaine, we don't have any added advantage of ropivacaine than bupivacaine. That's what I feel. You are muted, sir.
Cardiac safety wise, does it really matter when we are giving a spinal intrathecal dose of bupivacaine or ropivacaine? It has been marketed on those lines actually, but many of us are really confused, so are refraining from using it widely, as there is as such no great advantage. I think at the moment I foresee. I would like your opinion on this.
Actually, as you said, it is right. It is maybe for blocks, it will be useful where there will be accidental injection into the veins, but not for this thing. As a dual drug, let us see that whether any effect, but do not have much added advantage on that. If you see the purely cardiac action, but no other, because action-wise it is same, and safety, I do not know whether cardiac patients giving bupivacaine, whether it is contraindicated. You give that, I have not seen that. Only it's intravascular injection or large quantity. With our 2 cc or 4 cc of bupivacaine does not have much difference.
I generally I have not used much of a ropivacaine heavy, but what I gather after interacting with many those who are using it, when it is used for shorter procedure with dosage less than 10 milligrams, it does have a positive effect on early mobilization and less of urine retention, especially when used for perianal surgeries or vaginal surgeries. Apart from that, once you go for say meniscectomies, which last not more than half an hour, 45 minutes, and for cesarean sections, anything more than that, when you have to increase the dose of ropivacaine, then bupivacaine actually doesn't matter much. That's what my gathering is after the interaction with the many those who are using ropivacaine heavy. Can you just elaborate further on this, sir?
See, what we do is when you add that dextromid or fentanyl for analgesia, that doesn't matter much about that thing. If you want to pure, earlier chlorprocaine came, where used, it was very erratic action. They were telling that it's only half an hour action, 20 minutes, okay. You give PPS sterilization or a short cesarean, the patient can be mobilized, but it had a very erratic action. In this, that I did not observe much immediate, because that patient urine retention or did not matter much. I did not. And again, I will have to see again more into that, whether that, because we are thinking of more of post-op analgesia, give that and with the additives. But action is definitely comparatively less than that. Duration of action is comparatively less. Motor blockade is less.
Okay. Okay.
It is less.
One of the person has asked. I think you already mentioned, but the question is that whether we can use 0.75% ropivacaine heavy for children in spinal space.
Yeah, we can. I have used. There is no this thing. We can use that.
And Dr. Rao has asked, and he has elaborated on his experience regarding comparison of dextromid as an additive and buprenorphine as an additive.
Buprenorphine I have not used. I have used only dextromid and fentanyl. Only these two I have used. Buprenorphine. Dextromid I have used around 7.5 to 10 mics. fentanyl around 20 mics.
Okay.
Because
Okay.
it's very difficult. How you use the 10 mics and this thing? Anybody? What is the method you use? How you?
1 cc series, sir. 1 cc series.
1 cc?
Yeah. Yes. We take separate 1 cc series. Without that, it is very difficult.
What I did to ask, that is my own method. I thought I took a 4 cc, 3.5 cc or 4 of ropiocin in one syringe, half cc of this thing. That means 4 cc. Each ml contains 12.5 milligrams. So keep it then dilute, because our cases, 3-4 cases within half an hour we do 2-3 anesthetists. Okay, take from that and mix so that we give the exact dose. Otherwise, it becomes difficult. So when more cases, dilute with the 1 ampoule of ropiocin, and that you take 1 cc from that and mix with that. That's what I used to give, do that, to give the exact dose. Otherwise, with taking this 10 mics from undiluted is very difficult. So dilution with same ropiocin and keep in a syringe. Because and don't allow the nurses or anybody to that we keep in this sterile bin, and we only take with the gloved hand and use that.
Dr. Mutha has raised his hand. Can somebody unmute him?
Yeah. Only about that cardiac, this one, that basically ropivacaine, what I found was the action comes a little bit slow. So the hypotension and bradycardia, which has to occur because of slower action, slower motor action, and slower sensory action, is less as compared to bupivacaine. So you get a better time to preload the patient and prevent hypotension. So that's the reason why you get less amount of hypotension and bradycardia with ropivacaine than with bupivacaine.
Yeah, that must be because co-loading goes along with that, and we get time. That's
yeah.
But hypotension does occur.
Hypotension does occur if you don't preload.
Yes.
If you give higher dose, even immediate hypertension also there. When we gave, sometimes the dose was more. Dose was given for cesarean section. It came down to 70 also, from 130 to 70 also within 3 minutes. Because in few cases, even the action was very fast. But usually it is a slow action. What we see is a very slow action. We have to wait.
Yes, sir. I have used it for a couple of cases for lower end femur fractures and arthroscopic cases which last for tourniquet time beyond 1.5 hours. I had to give higher doses along with additives, and there was a significant hypotension, and I did not find any difference in bupivacaine heavy and ropivacaine heavy when I used any dose beyond 2 cc. That is my observation after 4-5 cases. So I may not be the right person to opine actually. Anybody else? Anybody else wants to join?
Yes. As I was discussing with Dr. Venkatgiri sir had mentioned that in hernia cases it causes more relaxation. The surgeon is more happy. Sir, you had mentioned once.
That was also, surgeon was telling that he was happy with more, but their literature that is less motor blood. But surgeon was happy with the relaxation than bupivacaine. I do not know how that he is happy with the relaxation better than bupivacaine. That's what he told surgeon. Because we have used for now maybe some 10-20 cases we have used for hernias, and surgeon is happy with the relaxation. He no tightness or anything.
Since
but their literature says it is less or motor blockade. Literature says it's less motor blockade.
Since sir is today with us, I would take the opportunity to just request him to request NEOM people why they have discontinued intrathecal levobutyrofen isobaric, because that was launched without much promotion and actually not without it was actually launched without much education of the anesthetic. So not many people were knowing how to use it, and it really helped us in COVID times. But during the end of second wave, it was just withdrawn abruptly, citing some reasons, and we are really struggling to get the ampoules of levobutyrofen.
Yeah, we have NEOM people on board. So we have put, I think Mr. Bhanushali sir is there on board.
I'm sure they have their valid reasons, but I have a feeling that if they had educated the anesthesiologists properly regarding the use of the levobuprofen in selected cases, I think it would have been a good commercial decision to continue.
Yes, Bhanushali sir, you want to say something on this?
Yes, sir. Am I audible to everyone?
Yes, sir.
Yeah. Good evening, all doctors. I'm very much thankful for giving us an opportunity to say something on this, the forum of the all top-notches anesthesiologists. Yes, sir, I do agree with you that the more concern of all anesthesiologists regarding about the levoanavin. We have discontinued that levoanavin because previously we had this levoanavin. We have never promoted this for spinal anesthesia. We have introduced this levoanavin for basically for the nerve block purpose, and where the 4 ml was not been consumed much. And before this COVID and before this the what I can say, before this pandemic situation, the usage of this segmental block is established. Before that only we have took the decision to discontinue it. But now as such, there is a much more request from all doctors are coming up. So we are thinking on it. So finally, I have put forward all the suggestions to our superiors, and definitely we will think something on it for levobuprofen.
Thank you very much, Balujani sir.
Thank you, sir.
Ganesh sir, I wanted to ask Dr. Venkatgiri sir. Sir, you said you use for hysterectomy, that is abdominal hysterectomy. So usually till the specimen is out, the surgeons require good relaxation and good sensory level. But I have seen with with the ropivacaine, the sensory level starts receding after 1 hour.
No, I did not have that because hysterectomy I used to 2 or 3 only, not many, but I did not have that much problem with that because the hysterectomy time itself was only 1 hour. That may be reason. It was 1 hour they finished the hysterectomy. That may be reason. So not wrong.
Yeah, every time whenever we are asking the experience of anesthesiologist, we should ask the timing of the surgery, duration of the surgery. But that is what really matters. Many a times we have moderate or slow surgeons, and even bupropion level starts receding.
Okay, Rao sir has commented that he has not experienced regression of level. Rao sir, you want to say something on this?
Yes, maybe 40-50 cases. Regression from 1 hour to
Dr. Prachi, can you mute yourself? Dr. Prachi?
जैसे कैसे बनाऊं मैं बेटा फिर हमारे हमें मिलेंगे
Varsha madam, please mute everyone except Dr. Rao.
Yes.
इतना 25 रुपीस का इतना बड़ा इसलिए लेके आएगी तुझे लगे
just last week one revision ACL was there, and the arthroscopic surgeon doesn't want any other except spinal anesthesia. This was ropin heavy with buprenorphine, and the surgical time was 3.5 hours plus. And the surgeon complimented me saying that this is something like a spinal epidural. Patient was comfortable, 3.5 surgical time, 3.5 hours with ropivacaine heavy and buprenorphine. I have so far never used dexmedetomidine as an additive in spinal anesthesia because I'm scared of that bradycardia.
So what was the dosage used, and was there urinary retention or patient was catheterized?
Urinary retention is always there with any narcotic analgesic or opioids you use. That is another bone of contention with my esteemed arthroscopic surgeon because they are again against putting a urinary catheter. But then comparatively with fentanyl, buprenorphine, or whatever narcotics you use for additives, Clonion I think has a better option for no urinary retention. But urinary retention I think is part of spinal.
What was the dosage used, and was there any hypotension?
No hypotension. I have not seen any hypotension with significant hypotension with Ropin heavy. But I think 50 cases is too less. But I've never exceeded 3 cc. Venkatagiri sir said he uses 3.5 cc. But even for an abdominal hysterectomy with sensor cane, I've never exceeded 3 ml.
For hysterectomies, there are some people who use 4.5 ml also. There are people. I have not. They take 2 ampoules and give that. There are people.
Yes, sir. Yes, sir. When we were doing laparoscopic hysterectomies with heavy bupivacaine, I have never used more than 3.5 cc's. But Dr. Milind Pol is there. You know him. He's a good friend of mine. He does a lot of laparoscopic hysterectomies with heavy bupivacaine, where he uses 4 ml also. But I'm doing more of segmental spinal now, where I do more of maybe 0.5 cc of heavy bupivacaine and 2 to 2.5 cc of levobupivacaine.
So, Dr. Venkatagiri sir, what you would like to tell ISA Borivali members about use of ropivacaine?
Definitely, there is no contraindication for use. That one is a short procedure. So we have to wait. That is one for its action to come. Don't say that it has not acted. We have to wait maybe a few minutes. We should be patient to wait for that action. It takes some time to act. That's the only thing. Otherwise, and definitely see in the titrated dose hypotension, maybe as he said that we do co-loading along with that. There is no hypotension. We don't see that much immediate hypotension. Maybe motor blockade is slow. It is little delayed. By the time our fluid takes care, and we need not worry about it. That is one thing. And
yes, sir.
We have to be patient in waiting for it to act.
Just part of this. What will be your views on now? These people have stopped making this isobaric levoanamine. Should they have been prudent enough to come up with heavy levoanamine?
Yes, I have not because now a lot of research coming about segments, which so far I have not started, because I think if it comes that we will also start the segmental spinal, because a lot of everywhere we hear about segmental spinal. Because now without that levo isobaric we can't go. I think otherwise people are telling.
Not isobaric. It is not isobaric. You spoke about the racemic and the levo part of it. I'm talking about the heavy levoanamine. Now the levoanamine which they came with was it isobaric? If they are promoting this ropivacaine heavy, which is isobaric, which was levo again. So what are your views on heavy levoanamine? That is racemic heavy sensorcaine, bupivacaine.
Bupivacaine, it has its own, because both are, it's like brothers and sisters. Cardiac patients, there's more safety. We have to say that is more safety and shorter duration. We go for ropivacaine. If you want longer duration action and without any problem, we go for the bupivacaine. But if he is expecting that you should have a slow BP for the cardiac patient, definitely we can use it, because there is no immediate follow-up BP with this patient. If a cardiac patient known we are giving a spinal, I think this is a better choice to give ropin than giving a anavin, so that it's a slow BP fall. We have the time for it to manage that, and it is not sudden BP fall is always a difficulty. This is a slow BP fall. Even if it is that is slow, we have the time, and patient body also will adjust. So definitely that CAD and this thing we are giving spinal, go for ropin than bupivacaine.
Thank you, sir. Thank you very much.
I guess we have completed most of the questions. Over to you, Dr. Shilpa.
Yeah. Now, can I invite our ISA Borivali member, Dr. Smita Rani Madam, to give a vote of thanks? Dr. Smita Rani Madam. Dr. Smita Rani Madam, can you unmute yourself? Varsha Madam, can you unmute Dr. Smita Rani?
Yes, ma'am.
Can you hear me?
Yes, ma'am. Yes.
First of all, good evening, respected ISA National President Dr. Venkat Giri, MSCISA President Dr. Manisha Katikar Madam, and Honorary Secretary MSCISA Dr. Avinash Bhosle, and the executive team of MSCISA. I thank you very much for sparing your valuable time and gracing this occasion. Good evening, my respected seniors, the eminent speakers, the participants. I feel immense pleasure to take the opportunity on the behalf of BSA team to propose the vote of thanks. I, with my deep sense of appreciation, thank Dr. Pankaj Gupta, who guided us in dealing with disastrous situation like how to face the death on table. Also, I thank Dr. Meenakshi Sundaram, whose expert's opinion definitely going to help us in treating or in dealing with this situation. I thank Dr. Rajesh Rao, who moderated the session very nicely and made it more expressive and practical. Thank you, Dr. Rajesh Rao. Now with all my, we are truly honored to have Dr. Venkat Giri, ISA National President, whose lecture enriched with Ropivacaine definitely is going to provoke all of us to use Ropivacaine in our day-to-day practice. Thank you, sir. I thank Dr. Ganesh Tendulkar, who nicely conducted this session and enlightened the practical tips. Now I come to our dietitian madam. I sincerely thank Dr. Shilpa Joshi, eminent dietitian, who elaborately analyzed each and every component of our diet and how we can improve on our dietary habits to make us more physically fit. And Shilpa madam, we really thank to you. We are going to inculcate all those habits in our day-to-day practice. I also thank Dr. Alpa Mehta, who conducted this session very nicely. Now, coming to our exercise, I sincerely thank Dr. Twisha Parekh, who explained the importance of exercise in our routine life. Rather, I feel exercise is important to physical fitness, to maintain the physical fitness, and I feel exercise, release of endorphin, fitness physically as well as mentally also. I feel physical and mental health, they are interrelated, and so the exercise has a great role in our life. And thank you, Dr. Twisha Parekh, for enlightening us with how to go about it and how to train ourselves in that field. I also want to thank Dr. Charushila Apsangikar, a trained marathon runner and trainer for marathon runner, who also guided us with tips on how to maintain our physique with a good amount of exercise so that we can remain physically and mentally fit. Last but not the least, I want to thank the organizing BSc team and the participants and the attendants who, with their great enthusiasm, made this webinar a great memorable evening. Thank you, all of you.
Yeah, thank you, Smita Rani Madam. Yeah, thank you, Venkat Giri sir. We thank Thank you, sir. Thank you so much for your presence. Thank you, Sachin Bhanushali, sir, and thank you all the PSA participants, moderators, and everyone. Thank you so much. And Dr. Preeti, you want to say something? Yeah, thank you, sir. Thank you. Can we end the meet, sir? Okay, sir. Thank you. Varsha, madam, you can end the meet.
Okay, ma'am.